Good morning, Dr. Wingfield.
Good morning. How are you, Mohammed?
Good. How are you?
I'm well, thank you. Is that Jennifer saying I see? You are on mute, my dear. It's so good to see your face.
I know. How many times have we heard you're on mute, like since this whole epidemic started?
Yeah,
Karen,
girl.
it's good to see you.
Same here. Oh my goodness, I miss you.
I miss you in Boston.
Yeah.
We had so much fun.
I know. I don't miss the cold though. I really don't. I'm just going to be honest.
Yeah, no, that's okay. That's all right.
Dr. Wingfield, could I bother you for one quick minute?
Of course.
Ask for a copy of your slides?
Sure. Let me see how I can do that quickly. Do you need that just as backup?
Yeah, just as backup.
Okay. Let me try to get you a link real quick. My lighting sucks. Let me just.
Hey, I'm sorry. I had to step away to refill my water. And Jennifer and Karen, I'm so happy that I could arrange this love fest for you two. My day is complete now.
It's not about you.
You know? He always had to take credit for stuff, right? Oh my God. All right.
Good times. This is going to be great.
Yep.
Hey, Alec, how are you? Guess he's on mute.
Very well. Good to see you, always.
Good to see you.
I'm still trying to decrease the megabytes file of my slides so I can send.
Yeah, Mohammed, I just sent you a link, a Dropbox link. So hopefully, let me know if you don't get that, okay?
Alrighty, thank you.
Just use your UIC login.
All right, Dr. Wingfield, I have your slides downloaded. Thank you.
Hey, Mohammed, can you hear me okay?
Yeah.
All right, great. I just want to make sure my volume is all right. I just move some things around.
Going. Welcome, everybody. Welcome to the 2020 Gupta Virtual Symposium. I'm really delighted to have this symposium, despite the fact that it's being hosted in our virtual space. In a moment, you'll be hearing from Dr. Enrico Benedetti, who will introduce our esteemed Dr. Dasgupta. And then John Stewart will be the host of ceremonies for the event. The theme of our event this year is the unequal burden of cancer. Have we made progress in the 2 decades since the Institute of Medicine's report? This is a timely theme. We are approaching the 50th anniversary of the establishment of the NCI. I don't think many of us in this room would have imagined the amazing things that have been achieved in these last 50 years. Sequencing of the human genome leading to novel precision medicines being applied after diagnosis, the establishment of a vaccine against papillomavirus that essentially can make cervical cancer a preventable disease, the use of harnessing our immune system to attack cancer cells through immune oncology. However, these achievements have not stretched to influence all of our communities equally. We're approaching the 55th anniversary of the Civil Rights Act, and I'm reminded of the fact that on today, 56 years ago, Martin Luther King was awarded the Nobel Peace Prize, the youngest at the time at the age of 35. Why are we still encountering problems with cancer outcomes in the Chicago catchment area? Problems that affect our patients in cervical cancer, colon cancer, lung cancer, breast cancer, among others. Well, we're here today to start to address that question. And we have an illustrious panel of speakers. They'll be introduced in detail, but I wanted to take this moment to personally welcome Jennifer Tseng from Boston Medical Center, Alric Willis from Thomas Jefferson University, Sidney Kimmel Medical College, Karen Wingfield from Wake Forest University, and Rosemary Rogers, a member of our own UIC Cancer Patient Brigade. Welcome all. We look forward to hearing your voices. As you all know, I've recently signed on to be the new Cancer Center Director, a role that I will serve with honor, but critical is the fact that our mission is to listen to the voice of the community. I pledge to listen and make that a part of our mission. And today we have the opportunity to hear from people at the front lines that are fighting for equity in cancer care and to improve understanding for all of us who are engaged in the enterprise of cancer care, research, and prevention. So at this moment, I'd like to now introduce Dr. Enrico Benedetti. Dr. Benedetti is the professor and is a professor and chair of the Department of Surgery. His activities have made an outstanding impact in cancer in our community, not only as a practitioner, but also supporting practitioners within his department and collaborating with other departments, supporting cancer research within his department, and supporting the UIC Cancer Center as an enterprise. We're very grateful for his support. Dr. Benedetti, I'd like you to now take over the mic, the virtual mic, and do the honors of introducing Dr. Dasgupta.
Thank you, Jan. It's my pleasure to actually be chosen to introduce one of my key mentor and dear friend. When Rob Wynn, Jan's predecessor as the head of our cancer center, proposed to dedicate this beautiful cancer meeting annual event to the name of Tapas Dasgupta, I was so moved and so honored. I spoke with Tapas, and he agreed that he's a modest man. He will not tell you what he has done for this institution, but he agreed for me to tell you a little bit of a summary that why it's so appropriate that this cancer symposium is dedicated to him. He came in 1969 and established the second division of surgical oncology in the entire country. Today, almost all the academic surgery departments have a well-defined division of surgical oncology, but in 1969, he was only the second in the country. He had an incredible run, both in the clinical and in the research sector. He was truly the triple threat. Dr. Dasgupta has been independently funded by the National Cancer Institute, or NIH, for over 35 years. In 1980, he was the recipient of a National Cancer Institute Cancer Education Grant and helped actually develop a section of medical oncology with funding for a full-time faculty in solid tumor oncology. In a way, he also helped to start the medical component of our cancer center. National Cancer Institute support him in establishing a computerized cancer registry for the University of Illinois Hospital and other affiliated hospitals, in particular Cook County, that was then under the control of Dr. Dasgupta. In 1985, the Division of Surgical Oncology received 3 program project grants, as well as multiple R01 and R25 grants. He also ran a 732 training grant specific for surgical oncology for 22 consecutive years. So in a way, he is really the man that brought specialized cancer care to our university. To me, that I met him as an intern in surgery in 1989, has been a role model, a mentor, and a dear friend. And I'm so delighted to introduce him to you. Tapas, please take over. Tapas, you are muted.
Did you get it? Can you hear me now?
Yes.
Yes.
Oh, you switch back to mute.
I did it.
Good now.
It's good. Okay. Too advanced technology for my my generation. But anyway, thank you very much. It is indeed an honor, and I am sure that my original thought of creating a cancer center to serve the community surrounding us, that means the I can say it, the community of color is now becoming a reality. It's a great pleasure for me, and I am honored. I don't know whether I deserve this honor or not, but that you will decide, but I am very pleased, and thank you to the new Cancer Center Director. I don't think I've met you, but I have heard a lot of good things about you. I'm sure you will help the center, along with Enrico, who is really a dynamo, will bring forth the dream of which I started with, is to serve the community to where we are located. Thank you very much, and let's proceed with the real thing I'm waiting to hear.
Thank you, Dr. Dasgupta. It's a real pleasure hearing from you. At this time, I have the honor of introducing Vice Chancellor for Health Affairs, Dr. Bob Barish, a relentless advocate for the Cancer Center, and that means a relentless advocate for our community and our patients. He's made sure that we are protected in this time of COVID-19 and fought to make sure that all patients have access to care. In addition, it's been a tremendous pleasure working with him over this last year, as my ability to understand and work within both the research and clinical space has been advanced largely through Dr. Barish's efforts in partnering with me on those. And for that, I'd like to thank Dr. Barish. At this point, I'd like to introduce him and allow him to say a few words in support of the Dasgupta Symposium. Dr. Barish?
Yes, Jan, thank you for the warm welcome. And I also must pause to congratulate you publicly on taking the helm as the director of the UI Cancer Center. Your outstanding service, even while serving in an interim capacity, has been diligent and admirable. Despite the global pandemic, you have stepped up to this challenge and led efforts to establish new pilot funding, manage the external advisory board visit, recruit and retain oncology, physician scientists, and connect with our community members. So under your direction, I know that the Cancer Center will continue to thrive. The combination of your deep scientific expertise and adept administrative leadership make you the ideal leader for the Cancer Center and our academic health enterprise. So once again, Jan, congratulations. So I'd like to also extend my thanks and recognition to Dr. Enrico Benedetti. We all know that Dr. Benedetti has a profound commitment to our academic research and healthcare mission. Most recently, the launch and dedication of the Surgical Innovation and Training Laboratory was an outstanding celebration that included 20 countries internationally for this celebration. So this lab will showcase an environment for advanced training and clinical translation that is sure to benefit our oncology services and our patients. The facility is more than impressive. It's a 22nd century facility that I hope all of you can visit in the near future. This laboratory is certain to be an asset in the Cancer Center's pursuit of NCI designation. And in fact, I'm eager for the UI Cancer Center's NCI application. I know that the University and UI Health fully support all efforts in this pursuit. The talented researchers, physicians, community coordinators, patient advocates, and staff continue to work persistently towards this common goal. So please know that we all recognize your efforts, and thanks to you all. So finally, I must recognize Dr. Das Gupta. As an esteemed researcher, physician, and leader, we have to thank you for bringing our cancer community together for this annual symposium. Your dedication and mentorship is remarkable. So thank you for your continued commitment to all the work that happens at the Cancer Center. And thank you to everyone, and enjoy the remainder of today's fantastic symposium. Thank you.
Thank you, Dr. Barish. Before we move on, I want to just say one more thing about Dr. Das Gupta. Having had the privilege of doing collaborative work with a variety of surgeons who are interested in the cancer enterprise, in particular while I was at Columbia University, I just want to emphasize what a special skill it takes to be a full-time surgeon, a full-time cancer researcher, and an advocate for cancer care. Any one of those jobs is a demanding job, in particular, being a surgeon and running cancer research. When I was writing grants with some of my collaborators, they'd be popping onto the computer between surgeries, and I was just so tremendously impressed with the dedication that was required. So I want to give another shout out to Dr. Das Gupta in recognition of how you balance that amazing triple threat of skills. And thank you again for putting us in the position to launch our Cancer Center and go for NCI designation. Very briefly, I also want to take this time to thank our administrative staff in advance for putting on the Das Gupta Symposium. And in particular, that starts with Dr. John Stewart, our leader for clinical oncology, who has organized this symposium. Dr. Stewart is also a triple threat in terms of his clinical practice, his advocacy on behalf of cancer patients, and leaders in the field of clinical and surgical oncology to diversify our workforce and to give recognition and opportunities to all who choose to seek leadership positions. He's organized a fantastic symposium, and now I'd like to ask him to go ahead and introduce the theme of the symposium, the speakers, and start the symposium. John?
Great. Thank you, Dr. Kodietsky. And again, I'd like to publicly congratulate you on assuming the role of the Cancer Center Director, and I look forward to outstanding accomplishments, including our submission for the Cancer Center Support Grant in the near future. It cannot be understated the impact that Dr. Gupta has had not only on surgery at large, not only on the University of Illinois, Chicago's cancer efforts, but also to me personally. Dr. Gupta was actually trained my first boss in surgical oncology, Dr. Ed Levine, and I have to tell everyone that Dr. Gupta is the stuff that legends are made of. And again, I'd like to publicly acknowledge his impact on surgical oncology at large and for me. So to begin, our first speaker is a member of the University of Illinois Cancer Center's Patient Brigade. This group of individuals is comprised of cancer survivors, family members, and supporters of survivors. The Patient Brigade was created to reflect the diverse ethnic, cultural, and socioeconomic groups of the Chicago area. Rosemary Rogers is a breast cancer survivor, and we're very thankful that she is here to share her story. Please welcome Brigade member Rosemary Rogers. Ms. Rogers.
Good morning, everyone, and thank you for having me here. Believe it or not, next week I will be a 25-year breast cancer survivor. And I had these great plans for this year, but like everyone else, plans change and we have to go along with it. When I was diagnosed, I was 48 years old. I only knew one person who had breast cancer, and that was my next door neighbor's mom. When I heard I had breast cancer, I was telling everyone because I had no idea what I needed to do. I think back about some of the things that I went through during that time, and thank goodness things have changed in 25 years, because what I did then, I probably would not do now. After I got treated for my breast cancer, I wanted to find out a little bit more about it. Back during that time, there was an organization called the Why Me Breast Cancer Support Group. So I happened to call them to get information about breast cancer. And I'll never forget, I told the woman, I just found out I have breast cancer. And her comment back to me was, what kind? Not knowing anything at that time, it was like, well, I hate to say it, I have two breasts. What kind could it be? But I made a point of telling myself, if I got through it, because originally I actually thought I would die from this, I was going to find out what this organization was about and go forward with them. I got treated, I had chemotherapy, I had radiation, and I have to say, I did get mammograms every year. But 8 months after mammogram, I found out I had stage 2 breast cancer. When I got finished with my treatment, I happened to go into the Why Me office one day to turn in some money from a race that I had been in. And one of the women says, are you interested in joining us? And at the time, you know, I didn't want to go to a support group. I figured a support group couldn't do anything for me. But I finally broke down. I went to a support group. I met a group of other women there who were able to answer questions for me, and it allowed me to talk freely. From there, I went on and I became a hotline counselor for Why Me. At that time, Why Me had 20 some odd chapters around the US, and we would get calls day and night from other women who had been diagnosed with breast cancer. It was really an eye-opening experience as to the treatment that some received and some didn't receive. After I got finished with that, one of the women at Why Me said, you should get involved in advocacy. There's an organization out of Washington called the National Breast Cancer Coalition. And yes, they do lobby Congress, but their main goal is to teach people like me the science of breast cancer. Because again, in 1995, you know, I knew there was cancer, but I had no idea what cancer involved. I just knew that we died from it. So part of the training, they taught us the science of breast cancer, where they had researchers and scientists come in. And it was a 7-day full immersion class in all the cancer, breast cancer involved for women. Once I got completed with that, someone said, hey, why don't you get involved in reviewing grants? And again, I knew nothing about any of this. I think sometimes it's best not to know what you're about to get into. And I started reviewing grants for Department of Defense. At that time, they received $150 million to do breast cancer research. I'd like to, well, at that time, I felt, and I'll be honest, that those involved in research, the doctors, they would all treat everyone the same way. It was a rude awakening for me the first time I happened to sit on a DOD grant, and we got to go to Washington, and we sat in this room with about 30 other scientists and researchers and advocates, and we reviewed this package of grants. It was eye-opening for me to hear the comments that were made about who could and who couldn't complete research that they had submitted a grant for. Being somewhat naive, I always thought that people would look out for my best interest, especially when it came to healthcare. I found out the first time that I did a DOD grant that it doesn't work that way. I would hear comments about the institutions not being able to do the research when you knew that the research institutions were minority-based institutions. And it was kind of disheartening. So when I came back from that first experience of doing a DOD grant, I made it a point to just open my eyes and see what was going on in the Chicago area when it came to research and how research was done on minority institutions, at minority institutions. Sad to say, the funding that was given out was not given out proportionately to the institutions. From there, I don't know how, but I got involved with the Dr. Susan Love Research Foundation out of California. In participating with them, their primary goal was they would do research, they needed participants for clinical trials. And what we would do, those on the advisory committee, is review grants and see if they were appropriate for breast cancer survivors to participate in. Her grants that went out were not grants that involved receiving any type of drugs. So I never forget the first time I reviewed a grant for them. We submitted it out to what they called the Army of Women. She has over 500,000 members nationwide. The majority of these women are not breast cancer survivors. They just have an interest in research and helping to discover a cure for breast cancer. The first time we submitted a grant out, it crashed the website because so many women wanted to get involved in helping discover cures for breast cancer. I've been with them since 2008, and each year, our main point is getting minorities involved. I can remember when I go out and speak with women about clinical trials, the first thing they tell me, they talk about Henrietta Lacks, they talk about the Tuskegee study. And I'm one of those that says, when you know better, you do better. I think at this point, the majority of us know about those things that happen, and we have a responsibility on both sides to make a change. When I go into minority communities and I talk with women and they tell me they don't want to participate because they don't want to be a guinea pig, I said, if you know that, make a difference. You know that if you think that's going to happen to you, consult with that person who's asking you to get into a clinical trial. Ask them why they want you to be involved. You know, it's a two-way street. I say that there's a little bit of blame on both sides. Researchers want to stay in their bubble and do what they do. I know I've spoken with researchers and they ask me, why don't my people participate in clinical trials? And my question back to them is, if you talk to someone else the way you just asked me about not participating in a clinical trial, you won't get people involved. I always say we all have to give a little bit. We have to step out of our bubble, and we have to work together. We can take this current environment that we're in right now where people don't talk. It's one way to look at it politically, but on the other side of the coin, when we don't talk to each other, it could mean a life being cut short. So I'm always going out into the community and talking with people about, let's work together. We can change the climate that we're in now. I look at 1995 when I was diagnosed and I knew one person who had breast cancer versus here it is 2020, and I've stopped counting the number of people who have passed, who are dealing with metastatic breast cancer, who don't know where they can go to get treatment. And we would like to think in 2020 that this doesn't exist, but it does. So again, I say to those of you who are researchers, those who want to go into this field, let's take that extra step and get to know the person that you want to work with. Thank you.
Thank you so much, Ms. Rogers, for your insightful journey. I'd like to remind the audience that you will be able to submit questions through the Q&A function on your screen, and we will answer those during at the completion of Wingfield. Dr. Wingfield is a radiation oncologist, and most recently, she was named Executive Director of the Meharry Vanderbilt Alliance. Dr. Wingfield has a national and international reputation with respect to understanding disparities in cancer. She is a radiation oncologist specializing in the treatment of hematologic and breast malignancies. And she's an implementation scientist focused on improving cancer outcomes for underserved populations through community-engaged research. Her leadership roles have focused on structured programming and building research collaborations to help ensure equitable access to care along the entire cancer continuum, from prevention through survivorship, irrespective of race, ethnicity, geographic location, or socioeconomic status. Please welcome Dr. Karen Wingfield.
Good morning, everyone. And Dr. Stewart, I want to thank you so much for that lovely introduction and for the invitation. I just want to, once again, I think everyone has stated this, is to congratulate Dr. Dasgupta. The fact that this type of session can happen, this type of conference, is amazing, number one. So that also speaks to the leadership of the Cancer Center of UI Health. So thank you all so much for this opportunity. And I love the way that this conference opened up, starting with the patient voice. How important is that? And I think sometimes we forget what our purpose is. So I want to thank Ms. Rogers for being willing to share your story, to share about your advocacy, about the importance of research, and about the importance of inclusion in research. I want to thank you so much. And so as Dr. Stewart mentioned, I am in the middle of a transition. I'm about to share my slides here, so hopefully we can get that up and rolling. But you know, I just recently was the Associate Director of the Comprehensive Cancer Center at Wake Forest. So my role there was as Associate Director for Community Outreach and Engagement. And part of that role was really, how do you integrate what's happening in the community? What's happening with patients? What's happening with individuals who may not yet have cancer? What's happening in the environment around the Comprehensive Cancer Center that can help to inform research? And how do we hear from the patient voice, just as we did with Ms. Rogers this morning? How do we hear from them about the issues that are important and relevant to them? And how do we integrate that into our research? And conversely, how do we then kind of communicate with our communities and with the patients to tell them what the things are that we are doing? So creating that bidirectional communication, I think that's really important and vital. I'm glad to hear that that's already starting as you and your institution is really looking to go for comprehensive cancer status. That is an important and vital component of the work that we do as researchers and cancer researchers. So I was tasked with talking about how far we've come when it comes to cancer equity. These are my disclosures. But I want to kind of start by thinking about this manuscript, if you will, this report that came out, The Unequal Burden of Cancer, which was actually started and commissioned in 1998. It was an assessment of the NIH research and programs for ethnic minorities and medically underserved populations. And they convened about 17 times. There was this advisory board that was convened. And the Institute of Medicine Committee really was charged with these few things: to review the status of cancer research relative to minorities and medically underserved populations within the NIH, to explain how well the research results are communicated and applied to cancer prevention and treatment programs, thinking about survivorship issues that might be unique to minority and underserved communities. And then the third charge was really to examine the adequacy of NIH procedures for equitable recruitment and retention of minorities in clinical trials. And so after 17 meetings, here are some of the recommendations. It was all about what should the NIH do? What are some of the things that the NIH could do to facilitate improvement around cancer equity? There were over 20 different recommendations that were levied, but they were kind of roughly in these categories. Burden: how do you kind of make sure that we understand the burden of disease? How can you impact things if you don't know where you're starting from? And so the recommendation was to provide additional resources to SEER. Many of us are researchers who are outcomes researchers will use the SEER database to kind of study what some of the patterns of care and outcomes might be, and to generate essentially materials that are hypothesis generating in terms of what some of the rationale and reasons could be. The other area was around research, and there was this general thought that the Office of Research on Minority Health should really help to oversee what's happening at the other branches of the NIH to make sure that there was inclusion. There was some emphasis on priority setting, really to increase representation of minority researchers into the different programs. Clinical trials was obviously an issue, but survivorship, again, how do you address the needs of minorities? And then finally, there was this kind of thought, we need to make sure there's monitoring and make sure that the NIH has accountability to US Congress and public constituencies. So how do you think the NIH has done? Well, here's the structure of the NIH, right? So as any government organization, it is complex. And so there are a lot of different moving parts. And I really don't want to talk about the NIH today. I'm not wholly qualified. I can certainly talk about the fact that we still don't have enough representation in terms of the number of minority researchers. But what I want to do is go back to the issue at hand. And this brings me to another report. So many of you may have seen the AACR has recently, actually last month, released their inaugural Cancer Disparities Progress Report. And it was actually really good. And if you haven't had a chance to read it, you can actually download the entire report. But what they also did was they actually had a virtual congressional briefing that they actually recorded. It's on YouTube. They recorded it on September 16th. So if you haven't had a chance to read the entire report, fine. Please at least go and listen to this legislative briefing, because at least it'll give you the general overview. But it was really talking about what the vision for health equity is for racial and ethnic minority populations and where we are to date. And so one of the important things that they did was talk about the trends. And what was fascinating is they did show that in 1990, right, so Ms. Rogers talked about her diagnosis in 1995. We knew that there were disparities that existed then. And in fact, that was the reason why the Institute of Medicine was asked to come up with this report on cancer burden. But there has been some improvement. So in 1990, you look at the disparity, there was about a 33% difference between Blacks and whites. And in 2016, that has been reduced to 14%. But let's take a closer look. I always think it's really important that you kind of dial down, because this is one of the challenges with using SEER database to do outcomes research in general, is it gives you a big picture, but sometimes it's much more important to dial down and to kind of see where that is. So again, remember, this report came out and really started looking at 1997 is when the commission, the Institutes of Medicine, was commissioned to do this report. And I find the timing of that really important. It was around a little bit after the 20th anniversary of the war on cancer. You all might remember that in 1971, Nixon actually signed into law the National Cancer Act, which not only did it allow for there to be 15 new cancer centers that were actually get some funding, but it also helped to reinvigorate the work that was happening at the NIH and the NCI around cancer. What was fascinating is that the report did show, the IOM report that was released in 99 or 98 actually showed that the NCI really wasn't focusing a whole lot on this. And so that was one of the important things that came out of it, that in terms of the funding that was going to research related to minorities in cancer research, there wasn't very much. But look at this timeline. If we look at where we were, Black men were absolutely dying of cancer at a much, much higher rate than any other group. You look at white men or Black women, but those gaps still persist if we look at the timeline even today. I guess the good news is that there has been some movement. This is a slide that I love to show. This is SEER database related information. And one of the things that I did notice in this most recent iteration, remember the data is always going to be 3 years behind. My last slide deck, I had information up to 2013. And what was interesting is that the lung cancer incidence for Blacks was much, much greater for whites. And now you can see they're equivalent. So that's good news. I mean, maybe there's some work that we're doing in terms of education or looking at other prevention strategies that are really working. But if you look across the board at every single disease that's listed here, these are the top 4 cancers in the United States: lung cancer, colorectal cancer, prostate cancer, and female breast cancer. Blacks are dying of cancer at a much higher rate than any other race or ethnic group. Still, despite the fact that incidence may not necessarily kind of be higher. And so, you know, we look at prostate cancer as being one of these prime examples. Is there biology, or is it kind of something else that we need to worry about? And this is the classic discussion. This is the classic issue that we face as researchers. Is it nature versus nurture? Is it the biologic determinants? Are there genetic variants that predispose African Americans or other minority populations to the development of cancers? Is it biology? Is there environmental factors that may impact how the genome is expressed? Is it comorbidities? And our comorbidities turned on and off and related to genetics or biology that then can impact how cancers are formed and the outcomes that patients have. And, you know, I'm a basic scientist, so I'm a biochemist. And, you know, I spent my dissertation work really trying to understand some of the factors that were different in Black breast cancer versus what we saw in white patients. I started looking at genomics. Then I started looking at proteomics. And then I wanted to do some comparative work by using laser capture to really pick out tumors and tumor cells themselves from Black patients and white patients and do some comparative analysis. The challenge was, at the institution I was at, I could not get enough tissue samples from Blacks to complete the analysis. And isn't that the case that many of us researchers find, that when we do want to do these comparative genomics or proteomics, we do find that there's an issue lacking with respect to tissue samples? And what that meant to me was that there is an issue with respect to access to care. Access to clinical trials, but also access just to care in general. And so this is where the nurture piece comes in, social determinants of health. And so I actually changed and shifted my focus away from bench research to thinking about these issues regarding access to care, and started to really think about community engaged research in a very different way. Socioeconomic status, access to care, sociocultural barriers, these social determinants of health can truly impact and drive not only the work that we're able to do as researchers, but frankly, and more importantly, are the outcomes that we see in the patients that we serve. And so this is an important concept for us to really talk about today, because, you know, oftentimes we want to say, oh, well, we're going to be doing all this work, we're going to be looking at genomes and biology, but when we look at population health, genes and biology only account for a very small fraction of that pie of what it actually takes to look at outcomes, right? Or what actually develops outcomes or what impacts outcomes. Medical care certainly is important, but it's really only about 20% of what happens. And the majority of what happens around health happens in the social context. It's the social ecology. And that is vital. It's really important to understand that. And I think part of the challenge in the United States is we don't describe health the way that the World Health Organization does. We oftentimes think of health as the absence of disease, and that's not all it is. It really is about well-being and social context, and how is that distribution of well-being kind of in our communities? Is it equitable? Is well-being equitable in our society? So the greatest predictor of health, when we're thinking about social determinants of health, is socioeconomic status, income, occupation, and education. And I have this wonderful documentary pulled up on the side here on this slide. If you've not had a chance to watch it, please do. I think there are about 7 episodes in this documentary. Unnatural Causes: Is Inequality Making Us Sick? The answer is yes. I don't want to give away the punchline, but we all know it. But what's fascinating about this, it talked about socioeconomic status, and it talked about zip codes. And we all know that zip codes matter. I know you do in Chicago. Zip codes matter tremendously, right? Where people live can dictate their overall survival. And it shouldn't be that way in this country, but it is. And the same thing for cancer. And so this documentary really highlights the importance of wealth. And I always talk about that wealth equals health. Check out this slide here, the black-white wealth gap. When we look at median net worth by head of household and by race, if we're just looking at white, black, it's fascinating. I mean, there's a massive wealth gap here in the United States. And when you look at the timeline, look at the age, things start to split relatively early on. Doesn't matter. I mean, it's an 18-year-old. What does an 18-year-old have? But it shows that there may be some structural barriers to the development of wealth amongst Blacks. But what strikes me about this curve is that when you look, it's on age. So on the bottom, the y-axis is actually age. X-axis, is age. And as individuals age, white individuals are getting more wealthy, not so much for Blacks. But this curve also represents cancer incidence, right? Cancer is a disease of older populations for the most part. And as we age, we have a greater risk for development of cancer. So what does that do? If we don't have the wealth, if we don't have the finances, when you come up against a cancer diagnosis, what does that mean? It means that there can be some practical barriers to healthcare. And we see this across the age continuum. Frankly, adolescent young adults is one of the truly underserved populations when it comes to cancer. But we have to understand that from a social context. When we're looking at our patients, trying not to make assumptions about who they are and maybe why they were late to their appointment, or maybe why they missed their appointment and didn't get to infusion on time, or maybe why, if you want to get them involved in research, there might have to be a talk about what their resources might be. That should be for every patient, frankly. Anyone we want to enroll in a cancer clinical trial, we should be talking to them about finances, period. Because we know financial toxicity is a huge burden. We know that financial toxicity related to cancer outcomes actually impacts individuals from all social strata. In fact, medical care is actually, and medical bankruptcy is the #1 cause of bankruptcy in the United States. Again, in this country, which should be a clarion call. But lack of finances leads to inability to purchase the necessary health services, whether it be medication, diagnostic tests, et cetera. So when we think about the cancer continuum, that's important to think about how finances impact that. But again, transportation. I mean, I was in Boston, and we had public transportation. It was pretty good. But if you lived in Mattapan, which is a town that's about 83% African American, and you're getting treatment at Mass General Hospital, which is really not that far away, about 7 miles, you might need to take 2 buses and a train to get to the cancer center. And that might take you an hour and a half. And what happens if you're employed and you are a wage earner, meaning you don't get paid if you don't show up? What does that mean? What does that mean for your cancer journey? And what does it mean if you don't have the ability to take leave from work? You know, you're sick. You need to have surgery. What does that do to your decision making as a patient? And what does that mean for your ability to participate in cancer research. So what is important to think about is what the National Institutes of Health has described and how they define health disparities. The differences, we know incidence, prevalence, mortality, and the burden of diseases, we know that. But the important thing that I always like to point out is it also is about the adverse health conditions that exist among specific population groups in the United States. And this was actually echoed in the report, right? So the Unequal Burden report, one of the recommendations was that the committee was stating there needs to be a greater emphasis on ethnic groups, number one, rather than on race. And you see, I was talking about black-white, because that's what all the data is, black-white, looks at race. But they actually recommended that instead they look at ethnic groups because, remember, race is a social construct. And so it implied a conceptual shift away from emphasis in terms of fundamental biologic differences among racial groups to an appreciation of environmental living conditions and other factors that may affect cancer risk. And so what I read this to mean, 1999, okay, many years ago, 1999, what I read this to mean is that stop talking about race as something that can impact outcomes, and let's start talking about racism and what that means. You see, what people fail to remember is that for Blacks in this country, they have not had rights for the majority of the time that they've existed here in the United States. People forget that Blacks were sold, that they were chattel, that they were beaten, that they were not provided health care as slaves, except to perhaps patch them up enough for them to work. And then even after the Emancipation Proclamation, which was supposed to quote unquote free folks, that there were systems in place that essentially guaranteed that they would continue to be disenfranchised. And so what does that do to health and well-being? What does that do? We know that social determinants of health are truly impacted by racism. If you look at socioeconomic status, again, I just showed you the wealth curves, right? That's actually very intentional in terms of keeping Blacks lower, in terms of their wealth capacity. What about the environmental exposures? And this is an important area of research that we need to think about. What environmental exposures might different communities be exposed to? If you look at low-income communities, there might be greater exposure to lead or asbestos or even dumping. We understand that that is something that racism can predicate. Stress levels. African Americans, for instance, have higher levels of cortisol and other stress hormones in their body at baseline. Is that the microaggressions that they face every day? Is it the fear of shopping while Black or jogging while Black? What is that from? And how can we measure that? Are there things that we can tangibly do as researchers that can help to tease apart how the issue of racism is actually impacting health outcomes? Because we know it impacts health behaviors, right? We know that all of these stresses and all of the things related to racism and how it impacts folks actually does impact health outcomes. And it's clear when you look at the leading health disparities, doesn't matter if it's obesity, cardiovascular disease, diabetes, et cetera, Blacks have the highest risk, the highest burden of each of these diseases. In fact, obesity, which we know is really starting to edge out tobacco as a leading cause of modifiable risk factor for cancer, 70% of African Americans are obese and overweight. Why is that? Is it perhaps because they live in areas where there are food deserts? Is it perhaps because of inactivity? Is it perhaps because how their bodies process fats, right? These are areas of research. Obesity research is something that really is important when we look at the cancer outcome landscape. You know, was going to put together a whole series of talk about breast cancer. It is a Breast Cancer Awareness Month. But I know that my colleague, Dr. Willis, is going to talk about this, so I'm going to leave this alone. But I do want to highlight the fact that, again, even though African Americans have the same incidence of breast cancer, they are 40% more likely to die of it. I mean, this is unbelievable. And it should be a clarion call, again, why aren't people jumping up and down? You know, we've got to do better. And we are going to do better. And it's symposia like this that's going to help us to do better, not only as researchers, but as clinicians, as practitioners, to really think about the barriers that patients may exist across the cancer continuum. I mean, look at this, lack of health insurance by race. And this was after the Affordable Care Act. And we know that there are efforts afoot to actually get rid of the Affordable Care Act. You know, I'm in North Carolina right now, and as part of my job as the Associate Director for Community Outreach and Engagement, it was really to look at the catchment area, to describe the catchment area. You know, what are the people that we serve? What do they look like? What are their demographics? You know, what are their sources of income? What are the other barriers that they may face? And in North Carolina, before COVID, some of the counties that we served had 20 to 30% uninsured rate. 20 to 30%. And this is not even looking at race and ethnicity. This is geography, right? Some of these rural communities. And that was before COVID. And since then, there's been at least 1 million individuals in North Carolina who have lost their jobs, which means they likely have lost insurance, if indeed insurance was part of their coverage. Because we know that, you know, employers have a very interesting way of avoiding having to cut pay for health insurance for folks. But this obviously is a major barrier. And so when we look across the cancer control continuum, from prevention, again, we talked about obesity being a risk factor, tobacco use. Glad to see that the numbers are shrinking down in terms of the impact of or the incidence of lung cancer, but I don't know all the details. I'll have to go back and look and see, you know, what are some of the reasons for that? Have we made some efforts, made some progress around tobacco control in the Black community? That would be wonderful, but diet is important. So prevention, detection, diagnosis, again, finances can impact the time, the lead time in which people can actually go and get their cancers diagnosed. Treatment, there's a whole paradigm. Again, I know Dr. Willis is going to talk about this around breast cancer, but important to think about. These are areas of active research that we can be working towards and looking at this with a lens of health equity. And don't forget survivorship. Again, the report had said, this is the unequal burden, said we've got to start focusing on survivorship issues that may vary by race and ethnicity. And I think that's an important thing that we've got to think about. What about clinical trials? You heard Ms. Rogers talk about the fact that, yeah, there's this thought that everybody gets treated equally. You know, I actually say we shouldn't treat people equally. We should treat them equitably. There are some people who are going to need a little bit more. They might need more information. They might need additional resources. They might need to have somebody help and assist with kind of navigating because they have 4 children at home and they may be a single dad and they're, you know, struggling to make ends meet and they just can't think about themselves. So what resources are we providing to enable individuals to participate in clinical trials? The fact that African Americans still comprise less than 3% of oncology clinical trials is atrocious. And we got to work on that. And there are some wonderful things that are currently being done. There are some centers that do an amazing job at making sure that there's equitable access to clinical trials, but there's still a lot of work that needs to be done in this arena. And again, I don't want to beat a dead horse, but again, thinking about how these social determinants of health really factor in to cancer outcomes is really a vital component of the research that we do. We've got to start to move towards how do we improve quality of care? And quality of care does incorporate, you know, are people satisfied with our care? It's not just about, you know, a checkbox that we have. Those are components, but we also need to start thinking about the communities that we serve. So I know I spoke a lot about African Americans and Blacks in the country, and the reason why, again, because this is the graph, this is from the AACR report, where if you look at that top line, that top yellow line, we see that, you know, Blacks are dying of cancer at a much higher rate. I mean, the beautiful thing is you see each one of these curves is going down, and that's really due to the amazing research that has been done. That's due to the research that has been done since the war on cancer, right? And the focus on making sure that we have adequate funding. We start looking at some of these issues, but we know we still have work to do in our American Indian population. And we need to continue to do the work in prevention, even though Hispanics don't have very high rates of disparities, except in some cancers like stomach cancer, et cetera, et cetera. It's really important to make sure that we continue our work around prevention for that community. So one of the things that I think is important to really think about as I wrap up is, you know, 34% of cancer deaths, 34% of cancer deaths could have been prevented if socioeconomic disparities were eliminated. 34%. And I'd like to think that we as a community, we as a people, we as a nation would really think about what Martin Luther King said, you know, all forms of inequality, injustice in healthcare is the most shocking and inhuman. And maybe there would be some moral imperative for us to think about health equity and cancer equity and to do research around that. And that's what I'm like, oh, this would be great if we could actually say that. But unfortunately, we currently live in a society where people don't think well enough of their fellow man to wear a mask, to simply mask up, to simply say, I value you, I respect you enough that I'm going to put a mask on because that's a way that I can participate in making sure that I'm protecting you. So unfortunately, the moral imperative isn't something that necessarily is going to work. So I always go back to my business case. There are tons of frameworks. This is one that's looking at assessing the economic cost of cancer health disparities. But I must say, and the report, the AACR report talks about this. We are spending $1 trillion annually on cancer disparities. And I'm not talking about cancer disparities research. I'm talking about cancer disparities that's costing $1 trillion every year. And if that doesn't mean something to you as a taxpayer, as a researcher, I mean, that, can you imagine $1 trillion going into research, cancer research? That would be amazing. So it's something that we have to think about as a nation, as individuals, as institutions, about how we can really work on this issue, how we as researchers can really make sure that health disparities and health equity are front and center. So I'm going to go back to the slide. Again, think about this unequal burden report. What should the NIH do? Well, clinical trials, I think there needs to be an effort to go beyond just reporting and recruitment and retention of minorities in clinical trials. I know the NIH asked that question, and everybody who writes clinical trials, I can tell you there's that standard language that you put into that's how you're going to be, thinking about minorities and women, right? But we need to go beyond that. And I think the NIH needs to do a better job and go beyond that. I must say that one of the areas that I think the NIH has done a fantastic job on is thinking about survivorship and addressing the needs of minorities. Many of you are aware of the NCORP research bases and the minority underserved community sites, which are incredible assets. But what I find fascinating is that when we do think about survivorship, I know the Wake Forest research base really does focus on survivorship. And when you look across the board at their clinical trials and enrollment, there's over 20% minorities. And I think other NCORP research spaces are doing an amazing job as well in terms of making sure that they're incorporating and being inclusive of different communities, and so that's important. And then instead of like monitoring, having the NIH increase their monitoring of themselves and reporting out to Congress, I feel like the NIH needs to do a better job of increasing researcher accountability. I can't tell you how many fantastic grant writers there are that can write a grant that will make your head spin. Like, oh my goodness, this is the best thing since sliced bread, and they're going to be doing all this community outreach engagement, but yet they don't even have Black people walking through their door. They don't have Hispanics that come to their cancer center. And so it's important to make sure that we're holding people accountable. Is there a way to incentivize people to do the right thing? And is there a way to make sure that we are looking at, do people have the capacity to do the work that they say they're going to do, and to hold them accountable if they don't reach those goals? Those are the sorts of things. And I say that thinking about Katie Porter, who is absolutely amazing. I love the way she calls out our researchers, right? So this is actually, for those of you who may not have seen this video where she called out the makers of Revlimid. Look, I'm a heme radiation oncologist, so a lot of my patients are on Revlimid. And thinking about the cost of this, people don't think about the fact that the NCI actually funded the clinical trials to make this drug available. And yet the company is making millions and billions of dollars off of this pill. Is there something that the NIH can do? Not sure. My hope is that we'll all engage in the process, that we'll all think about research from that perspective. And I want to thank you so much for your attention. And again, I want to thank Dr. Stewart and the rest of the individuals responsible for this conference for inviting me to speak today. Thank you so much.
Wow. Great presentation, Dr. Wingfield. And of course, she did not disappoint with her framing of the issues around disparities for cancer care, both in a financial and a moral imperative viewpoint. I'd next like to turn the podium over to Dr. Alaric Willis. Dr. Alaric Willis is an associate professor of surgery at Thomas Jefferson University. He is also the vice chair of the Department of Surgery and an associate dean for faculty development at Thomas Jefferson University School of Medicine. And he is an associate member of the Sidney Kimmel Cancer Center. Dr. Willis conducts cancer health disparities research, specializing in surgical oncology and care for a diverse population of patients. Please welcome Dr. Alaric Willis to present his findings on disparities in breast cancer screening, treatment, and outcome, a crisis in need of action. Dr. Willis.
Thank you very much for the honor of presenting today, and a special thank you to Dr. Stewart for the invitation to speak at this event honoring a model surgical oncologist. I should also say it's indeed a special honor for me, since my wife, Allison, is actually a UIC School of Medicine graduate. We met after she graduated down at WashU. We were both in residency, and she's born and raised in Chicago. So unfortunate that I couldn't have the opportunity to come out to Chicago, but I'm really honored to be here this morning. I have no disclosures. In this talk, I'm going to present to you an historical perspective on systemic disparities that impact health. And we'll use breast cancer as a paradigm for cancer disparities. We'll discuss specific disparities in breast cancer treatment and discuss how multifaceted problems require multifaceted solutions. Let's begin with this Healthy People 2020 definition of health disparities. As you see here, a health disparity is defined as a health difference closely linked with social, economic, or environmental disadvantages, which we learned more about in our previous talk. And particularly of importance, health disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles to health. This slide, I think, is really poignant and demonstrates the reason that we need disparities research. You can see here, you see the two gentlemen in this cartoon who look, as you would expect wealthy individuals to look, discussing how the poor are getting poorer, but with the rich getting richer, it all averages out in the long run. And this is exactly how disparities persist and become exacerbated without people really realizing. To give you some background on what disparities really mean, I think this study is an excellent one that really got into socioeconomic health disparity many years ago, looking over the 20th century, from the beginning of the 20th century to the second half of the 20th century. What you see on this slide, you have looking at coronary heart disease in England and Wales. So this is a homogeneous population, and you're looking at high incidence of coronary heart disease, low incidence of coronary heart disease, how that corresponds to poor areas, wealthy areas, but most interestingly, that also directly corresponds to the neonatal mortality in the early 1900s. So you had children dying in these poor areas. Those who survived then had an increased incidence of heart disease later. So socioeconomic health disparities persist lifelong. Coming here to the United States, this is what's quite striking, important, and persistent that we need to appreciate. The Federal Housing Administration, and I should say to you this, I really learned more about this during my time at NIH, where they actually went in detail in teaching us about this. Federal Housing Administration was established during the New Deal through the National Housing Act of 1934. The FHA, as we all know, became the largest lender and insurer of mortgages in the United States. Through this, they established the Underwriting Manual, which institutionalized racial and ethnic segregation at a federal level in housing, lending, and business development, with a mapping practice that marked areas where no investment would be given with a red line. The red line areas corresponded to Blacks in particular, with similar or other undesirable markings for other ethnic groups. This occurred nationally. And this persisted from 1934 until the Fair Housing Act of 1968. Private lenders would not loan in those areas. And with this, you had 3 generations of wealth that were developed in the United States where Blacks systematically were denied that opportunity. On this slide, you can see an example of a redlining map. J.M. Brewer designed this map. This is from 1937, and it was based upon his earlier maps because segregation and housing had persisted before that time, but this demonstrates clearly redlining in Philadelphia, racially and ethnically segregated areas to deny financial investments. And in this slide, I'll show you here, this is how Philadelphia was broken down, and sadly, I'm sure you know in Chicago, you had similar issues. And I'll show you here in Philadelphia, this is North Philadelphia, South Philadelphia, West Philadelphia. I'm very familiar, while I grew up in Atlanta, Philadelphia is my adult home. I went to med school at Penn out here in West Philadelphia. When I came back for fellowship at Fox Chase, it was in a very wealthy area, which is this blue and green area here. My first 7 years, I practiced at Temple, right in the center of this red North Philadelphia area. And now I practice at Jefferson, which was in this business and industry area. For me, I lived in West Philadelphia. I lived in Society Hill in this business area, which was revitalized. And I currently live out in this area here, which on the one hand, it's very nice, but you'll see what these disparities really mean. This is a close-up of it, and it shows you right here on the legend, this is what they used. The blue areas were the best, or blue-green were the best, still nice in the blue. The reds were called hazardous. They would not give loans in those red areas, North Philly, South Philly, West Philly. And if you want to know in more detail exactly what was written there, 2 examples from documents of that time. If you want to be specific about what group, that was written on the document. Are they present? Yes or no? And then there was no funding. Infiltration, and then also those who were foreign born. It wasn't just Blacks, but all groups. In this area, German American population, Broad Street properties, speaking of Jewish encroachment. So there were other groups that were scorned. However, this is what defines institutionalization of racism. To show you how enduring that is, actually this morning, as I was getting up, getting dressed, I don't know if you guys saw this on Good Morning America this morning, they showed this story on the enduring modern impact of racial bias in home value and wealth. And those of us who own homes and those of us who don't know that this is the fastest pathway to wealth. $250,000 tax-free, $500,000 for a couple tax-free when you sell your home. That's how wealth is accumulated. And in this story, you had a couple, Black woman, white man, baby. They were going to get their home appraised because they were looking to pay off their home, get equity out of their home. And she had set up her home for the appraisal to come through. The appraiser came with a result that was so low that even her bank couldn't understand it. She was concerned about the effective race, and what she actually did was take the pictures of herself and their child down, leaving only his pictures up for a second appraisal. And this is the difference. 40% difference in the appraisal when all she did was take down the pictures that showed that the house was owned by a Black family. With my interest in redlining, I actually had done this research in Philadelphia. Looking through the 2010 census data, I looked at North Philadelphia, as I showed you, Chestnut Hill, which is the area where we live now, Society Hill, which is the area where we used to live. And you can see here striking differences in concentration of the populations, population density, striking disparities when it comes to racial makeup, median home value, market disparities, average adjusted gross income, market disparities, 5 to 6 times. The percentage below the poverty level, again, these are modern stats that correspond to the map from the 1930s. You can also see the single parent households, 75% in North Philly, down to only 10 to 13% in Chestnut Hill and Society Hill. even issues of sex offenders. When we talk about stress, as we did in the last talk, you can imagine what levels of stress there must be when you have this much of a difference in the threat to your children. Education, massive differences, nearly 40% with graduate degrees in these areas versus less than 2%. Now, what's also interesting and goes along with that Good Morning America article or story is when you see these home values, even in nicer areas, you see that there still is a difference along racial lines. So while it increases, there still is a persistent difference between blacks and whites. While you don't see that in the Asian ethnicity here, which is noteworthy, you also see it among Latinos, a big difference within the same zip code. Moving on to breast cancer. Screening efforts have made a substantial impact in early diagnosis of breast cancer. The majority of those cancer cases are stage 1 and 2, but ethnic and racial disparities still do persist in screening outcomes, even for early and localized disease. And when you look at women with early stage breast cancer, they have the wealth of options. We can offer them all of the different treatment options, and the majority of them do choose breast-conserving treatment options. And this is where we get back to our discussions about the cost of cancer. When we're talking about breast cancer and it being stage dependent, not only are we discussing the fact that you have the wealth of options, but we're also talking about a disease that's much less costly to treat. Breast cancer is the most costly cancer in the United States, costing $20.5 billion for the year 2020. However, when you look by stage, you can see our DCIS patients, $60,000. Stages 1 and 2, $82,000. Market increase to stages 3 and 4, which both are around $130,000 to treat. Early detection will reduce breast cancer treatment costs. And let's keep in mind, as we're looking at these 6-figure numbers for stages 3 and 4, a mammogram costs $100. Now, Black women with breast cancer present less often with localized disease, more often with later stage disease, regional or distant. And additionally, they do have worse outcomes for every stage. And while there are worse outcomes for every stage, let's keep in mind that for localized disease, we are looking at survival rates for all groups in the 90s. Mammography is the mainstay of screening for breast cancer. The Affordable Care Act mandated that insurance companies have to cover annual screening mammograms for women over the age of 40 without a copay. Again, as I said, that's about a $100 test. However, that now is controversial. In our world, is cancer, whether it's surgeons or medical oncologists or radiation oncologists, we look towards groups like the NCCN, who recommend, as the Affordable Care Act supports, beginning screening at age 40 with annual screening. And that information was actually based upon American Cancer Society studies. However, now the American Cancer Society has changed in recent years and recommends starting at age 45, annual screening 45 to 54, and then changing to biennial screening greater than or equal to 55, which is a little concerning given that the average age for breast cancer is 62. The frequency increases with increasing age, but they're actually recommending decreasing the frequency of screening. And what's most concerning right now, particularly as we're talking about the potential of the abolishment of the Affordable Care Act, depending upon what happens in the next several weeks. When you look here at the U.S. Preventative Service Task Force, which is what is used by most of the primary care physicians, the gatekeepers who see the patients before we ever see the patients as cancer specialists, they recommend biennial screening starting at age 50. And that has had a major impact, as those of you who take care of breast cancer patients have probably seen in your practice, with patients presenting, believing that they aren't supposed to be screened until age 50, presenting with breast cancers in their 40s. Now, it's important that we understand, and primary care doctors and cancer specialists all understand exactly what was written in this document. And they actually gave a grade of B to age 50 and above, and a grade of C, actually, to age 40 and 40 to 49. They did not say that you should not get screened. And this slide demonstrates here, it's important to understand that they stated in the beginning, women who place a higher value on the potential benefit than the potential harms may choose to begin screening at ages 40 to 49. They actually, again, recommend every 2 years. And they also say the balance of benefits and harms is likely to improve as women move from their early to late 40s. So it's important to understand in this document that they did not rule out early screening. They actually said that there's a role for early screening, and they found that when you look at the numbers, there is this balance. The positive balance does occur at some point in their 40s. So I think it's important for us to continue to stress age 40 for screening and annual screening, and also important for us to understand that documents like this could have a huge impact on us as surgeons, radiation oncologists, and medical oncologists taking care of breast cancer patients. Another very important thing for the population that I'm focusing on in this study is down here. This task force admitted limitations on their systematic review. This was not original research. This was a systematic review in which they looked at studies the studies that they analyzed were primarily of European women from Norway and Sweden, not of the diversity of women in the US, particularly not African American women. So with that said, age really does matter. Breast cancer incidence does increase with age, and there is a substantial increase in risk that starts at age 40. Furthermore, 20% of breast cancer cases, 20%, occur under the age of 50. 11% of breast cancer deaths occur under the age of 50, meaning before those recommendations for screening would even come into play. Delaying screening until age 50 will have impacts on delays in diagnosis and survival. Race matters. Black women have the highest incidence of breast cancer for ages under 60 years old and the highest mortality at every age. Now, when we talk about screening mammograms, it's another important thing for us to understand is this study was very interesting. It would tell you that we've had tremendous impacts on screening. It's fantastic. It found that there were not substantial differences in self-reported recent mammography by race and ethnicity. That would tell you that all disparity issues are solved. Super. It would also tell you that what do we need to focus upon? Those with less education, no insurance, or more recent immigrants. And this is all based upon asking patients, have you had a mammogram within the past 2 years? But as we as researchers are familiar with, there is recall bias. And there's also selection bias in terms of who is selected. When we look at many of these studies, as was presented in our last talk, when you're looking at clinical trials and the low percentage of Black participants, you can have a selection bias in terms of who you've asked. So I think that this study here from 2017 is an excellent example of the depth to which we need to go when we're doing disparities research. And what they looked at was 39 studies of mammography registries, not what people reported, but what actually occurred. And they found that Black women were 19% less likely to have screening mammograms than white women. And this was regardless of age, looking at 40 to 65 and women over 65. This actually highlighted utilization, not just reported receipt. Looking further into this, Black women have nearly the same incidence of breast cancer as white women overall in the United States. However, they do have a 42% greater chance of death overall than white women. And at a state level, for me in Philadelphia, the state of Pennsylvania has one of the highest disparities in a black-white death rate from breast cancer at 1.49, meaning that Black women are nearly 50% more likely to die from breast cancer than white women. This disparity exists in every state, from 8% up to 60% higher mortality for Black women than white women. And for this talk, I identified over here that Illinois has a rate of 1.39, nearly 40% higher death rate for Black women with breast. Within the city of Philadelphia, Black women are 36% more likely to die from breast cancer than white women. And Philadelphia's average breast cancer rate was 25 per 100,000, which is, again, higher than Pennsylvania's 22. Again, as a part of my practice, taking care of breast cancer patients, breast-conserving treatment is the procedure that we, again, like to do most often for those women presenting with early breast cancer, early stage breast cancer, although, of course, this is a component of shared decision-making because we will do mastectomies, nipple-sparing mastectomies, skin-sparing mastectomies for those who have a preference in that direction. But for those with breast-conserving treatment, you need a partial mastectomy with clear margins and then whole breast radiation receipt and completion of that treatment on time. If radiation therapy is not performed or completed in a timely manner, recurrence and mortality rates are increased. And the reason that I bring that up in terms of focusing on treatment, this is something that I actually started during my time at Temple in that North Philadelphia area. I wanted to look at what are the risk factors for timely radiation therapy completion after breast-conserving surgery at a granular level, at an institutional level. So we looked at 261 patients. And again, this is where I think disparities research is particularly interesting, because what we found is there was no difference in days to radiation therapy completion according to ethnicity. Blacks at 46 days, whites 46, Hispanics 48, no difference, no problem. Really no difference statistically in radiation therapy completion. High 80s, high 90s, again, you would say, well, there are no disparities. However, there were significant differences identified in the percentage achieving timely radiation therapy completion in the areas of race and age. White women, 78% completed on time, whereas for Black and Hispanic women, that number was nearly down to 50%. Strikingly, for those younger women, 43%. Mind you, again, that's that group, as you may remember the slide I presented earlier, looking at the 2010 census data, 75% of households in that area, single parent households. You're looking at young women that may be single parents, have a job, have a number of competing interests, most at risk of not finishing on time. A multivariable logistic regression model demonstrated the groups most at risk were Black, age less than 50, Medicare patients, and Medicaid patients. We wanted to do further analysis at zip code income level, but within that area, again, going back to the red line map, 80% of patients were in the lowest income bracket. Therefore, you couldn't do any analysis of that sort. Now, more recently, and you can see here in this paper that we just published last month in the Red Journal, the journal sponsored by Astro, we looked at trends in use of hypofractionated whole breast radiation in breast cancer. So one of the biggest advances in breast-conserving treatment over the past 10 years in the US has been the expansion of hypofractionated radiation, in which case you decrease a standard treatment of potentially 6 weeks including full treatment and boost dose, down to 3.5 weeks, which can have significant impacts on people just in terms of their daily life, being able to take their treatment and maintain their job, versus as well as the actual effects on the patient. The skin effects, the skin burning effects from radiation are much less with hypofractionated radiation when you look at studies on the whole, and patients have shared that with us as well. So what we did was use the National Cancer Database to look at 259,000 women over the course of 2012 to 2016, particularly selecting that time because ASTRO guidelines supporting the use of hypofractionated radiation started in 2011. They again updated them in 2018 and even broadened them further, and that'll be the next study as the data rolls in. But what we wanted to look at was 2012 to 2016, what impact did that have, and also what disparities might there be. You can see here in our consort diagram, the breakdown from traditional radiation to hypofractionated radiation. And this shows you over the years, hypofractionated radiation had a marked increase consistent with guideline recommendations from 2012 to 2016, which is great. We see that right here, hypofractionated radiation increases significantly. In these raw numbers, you can see that it was along age lines. There was a particular study in 2010 published in the New England Journal of Medicine that did support expanding the age to women 50 and above. In the US, it had been 65 and above. So you can see those increases here, and that the younger women did not get this treatment as much. And that's understandable given that there were some insecurities regarding expanding it into a younger population. However, there was nothing reported on this regarding race. And you can see here the marked difference between Black and Hispanic women, or Black women and white women in this treatment. Further here, there was nothing regarding insurance reported, but you can see these low numbers in Medicaid patients. And also nothing regarding education, however, lower numbers among zip codes with less highly educated patients. And then specifically looking at the odds ratio, what was really reassuring was over that time with guideline recommendations, you had a 6-fold increase in the use of hypofractionated radiation, which is excellent. However, Black women were 18% less likely to receive it. Medicaid women, 15% less likely to receive it. Those in the highest income, 25% more likely to receive this treatment. Our tumor results are here. Again, we looked at hormone receptor, tumor size, whether margins were clear, whether chemotherapy was administered. And as you would expect, hormone receptor positive patients were more likely to receive it. HER2 positive were less likely. Larger tumors were less likely to receive it. Again, everything clinically that you would expect. Chemotherapy patients, likewise, less likely. What's also striking is we looked at provider level data, which is something you can do with NCDB. And we identified that academic centers, UIC, Jefferson, twice as likely as community centers to offer their patients this treatment. That has to make us think about the fact that there do seem to be disparities, whether we're looking at clinical trials, which are coming out of academic centers. Where exactly are Black patients going? They may not be participating in clinical trials, but they also may be getting their primary care at a community hospital where they may not have the opportunity to have the state-of-the-art treatments that are recommended. And even when you're looking at comprehensive community cancer centers and integrated network centers, still a stark difference. With distance, those traveling a further distance, this is good. Shorter time of treatment for patients traveling a greater distance, that's an excellent benefit for those patients. And here it's quite dramatic and unexpected, the differences in regions across the country, with the mountain region far and away being the region that most took in this hypofractionated radiation treatment. So in conclusion with this study, the guidelines supporting the use of hypofractionated radiation were associated with a dramatic increase in the use of it in the United States. However, there are substantial identifiable disparities in the uptake of it at both patient and facility levels. By understanding which patient populations are at risk of not receiving it, we can improve our use of it in the United States, potentially leading to reduced healthcare costs, given that there are fewer treatments, and increased patient satisfaction, which has been demonstrated in studies comparing patient satisfaction of traditional hypofractionated radiation for breast-conserving treatment. Now, that's one area of interest for me, is the treatment of our patients. The other area that's been striking to me is what actually is going on with our patients outside of the time of those 15-minute office visits with us, those short periods of time that we take care of them. As you saw in all of the slides that I presented about the socioeconomics, the environment in which they live has a tremendous impact on them. And to further study this, I continued a collaboration with a biostatistician that I worked with on the study that I did at Temple. And we continued our working collaboration, and more recently received an R01 award for a multi-institutional study focused on African-American families fighting parental cancer together. And in this study, what we're doing is looking at solid tumor cancers, African-American patients with children ages 12 to 18, solid tumor stages 1, 2, and 3, children of that age group, randomizing them to either therapy sessions with just the patient, therapy sessions with the patient and children, with the goal of trying to further identify how can we best help these families through this. One of the reasons that we have this is there are no studies focused on African-American patients and the stress of cancer. The studies that are used are based out of, are actually based upon European studies. There are no studies on this population in the United States. And we hope to really gain some information, learn how we can best help these patients. And for me, this really comes out of an experience that I had with a patient where actually she had a GIST. I removed a GI stromal tumor and did very well. She was only 34 years of age and had missed her medical oncology appointment visits on 2 separate occasions. Had her come into the office because she was going to all of my appointments. She came in with her husband. She worked at a bar and had to do heavy lifting. Even after abdominal surgery, they had her lifting 75-pound crates and the like. Her husband was a sanitation worker, really good people, really nice people with 2 young kids. And why had she missed her medical oncology visits? Because on that day of her visits, her kids, her older son who was in middle school, knowing that his mom was going to see the medical oncologist, really just had a breakdown at his own school, slammed a door, yelled at a teacher, yelled at the school nurse when he got sent there. The school called her and said, "You have to come pick him up now or we're calling DFS." So on 2 separate occasions, deciding between job, child, her own medical care, she had to choose her child. She had to go pick him up. Husband was on the sanitation truck. She couldn't get him off of that truck. These are the kind of issues that our patients deal with that we need to better understand so that we can take the best care of these patients. In conclusion, disparities in breast cancer exist in screening, extent of disease at presentation, biology and adequacy of cancer treatment, and survival, which are complicated by long-standing disparities in socioeconomics and population health. These multifaceted disparities require thoughtful, multifaceted approaches to solutions. There's currently not a consensus regarding screening beyond the fact that it should occur. This confusion disparately affects Black women who have an increased incidence of breast cancer at younger ages. Starting at age 40 may optimize benefits for deaths averted and life years gained for asymptomatic average risk women. Improvements in screening rates are associated with increases of incidence in breast cancer, but also with decreased death rates. However, the improvements in screening for Black women may not be as good as reported. We can have impacts on screening with early education and an appreciation of just how institutionalized some of these disparities have been. Inadequate screening of young women impacts Black women to a greater extent because breast cancer is relatively more frequent among this group of women, and the cancers that develop are frequently those types that progress faster. Disparities in treatment exist at both patient and provider levels. Patient-level disparities reflect those all too familiar regarding race and socioeconomics. Provider-level disparities raise concerns regarding quality of care across facility types. But we also must admit that provider-level disparities also raise concerns regarding bias that must be acknowledged and addressed. In summary, what can we do? We can research, educate, act, and lead. Keep it real. Thank you.
Wow, that was an outstanding presentation, Dr. Willis. And again, we will collect questions during the course of the panel and then have a panel discussion after our last speaker. It is my pleasure to introduce Dr. Jennifer Singh. She's the Utley Professor and Chair of the Department of Surgery at the Boston University School of Medicine and Surgeon-in-Chief at Boston Medical Center. She is a highly regarded surgical oncologist and gastrointestinal surgeon whose practice encompasses the entire gastrointestinal tract. She has led a group of diverse physicians at the Beth Israel Deaconess Medical Center in oncology research, education, and care for GI endocrine breast malignancies, as well as melanoma and sarcomas. She was recruited to Boston University in 2017 as the chief of surgery. Her current research interests include developing models for cancer treatment sequencing strategies, cancer biomarkers, and healthcare disparities and outcomes research. She serves on the editorial board of several journals and is the deputy editor for JAMA Surgery. Please welcome Dr. Jennifer Singh.
Thank you so much for that very nice introduction. It's great to be here with some of my good friends, some of my really old friends, and none of you are old, but some people I've known for a long time. And of course, what an honor to participate in a symposium named after Dr. Gupta. It's just amazing. It's a legend in surgical oncology, and I'm really grateful for the opportunity. Let me see if I can share my screen. Get this right. So I want to take you on my personal journey from disparities research, starting in disparities research, to where I hope we're heading toward health equity and cancer equity. These are my disclosures, none of which has anything to do with what I'm talking about today. This is last year's annual report, which is what our goal is, my goal is, in our department, at our medical center, and building a healthier future for all. What more could we ask for? So how did I get introduced to disparities research and cancer disparities in particular? So I grew up in a very multi-ethnic environment, but I actually moved to Boston in 1995, and it spent almost 10 years at an institution that Dr. Wingfield knows extremely well, was extremely well trained, had a great time. And you would have thought, based on the cancer patients I operated on as a resident, or helped operate on as a resident, that I was in almost an entirely white city. I remember as a chief resident or super chief resident, I finally did a Whipple, and I did a lot of Whipples in residency, on a non-white patient, and it was remarkable, and it happened to be a Japanese national that was in town for business, and we did his Whipple. And I remember it was quite a novelty to me. And it wasn't until I actually moved to the great state of Texas, to Houston, Texas, that I actually started to take care of patients with a somewhat more ethnically mixed population. At that point, Harris County, in which Houston is located, had a agreement that people with cancer within Harris County could get treatment at county expense at MD Anderson Cancer Center. So I finally was operating on a relatively diverse section of patients, and people at MD Anderson are treated once they're in the system without looking at their insurance or their ability to pay. But nonetheless, as a fellow at MD Anderson, I noticed that there seemed to be a difference. It's just an observation that many young African-American women did not appear to me to be getting reconstructed after mastectomy for breast cancer, whereas their white and Latina peers appeared to be getting reconstructed. And I made this observation to Henry Curer, who is a very funny breast surgical oncologist, a brilliant breast surgical oncologist down at MD Anderson, and he said, it's just not true. We operate on everybody exactly the same. We're not compensated any differently. We just treat people, we're colorblind. We treat people without paying any attention to it. And that was true. I do think they were treating people without paying attention to what ethnicity people were, but as we know, that actually leads to making decisions, just like in that eloquent example that Alaric just showed about from Good Morning America today about the mortgage, not the mortgage, the valuation of that woman's house, right? So to their credit, at MD Anderson, two white guys, Stephen Kronowitz, who's a plastic surgeon, and Henry Curer, despite their anxiety over my looking at the data, said, go ahead, prove us wrong. Go ahead, look at all of our data. And I think they hoped to be proven that there were no disparities. And what we actually found was that in fact, African Americans were significantly less likely to be reconstructed, even after adjustment for after mastectomy for cancer. And Middle Eastern is a little bit of a different group because these are people that were coming in from far away, and they generally were getting reconstructed back in the Middle East. So I went back and looked at these 1,000 charts. In those days, we had actual charts with the actual paper charts that you had to order from actual medical records, and try to analyze why. So in disparities research, it's fairly straightforward to point out that there are disparities, but to figure out why the disparities exist is more complicated. Remember, this paper is from 15 years ago, but I actually looked to see whether or not Black patients were offered a referral versus white. They were less likely to be offered a referral, meaning I looked at the medical record and it did not mention the referral. They were also slightly less likely to accept the referral. Now, there is some data that African-American women have less body anxiety after mastectomy than white women, or potentially white women have more body anxiety afterwards. So there may be something to it, or maybe, as some of the things we've talked about, maybe they have jobs that they have to go to that they can't miss from work, that they cannot put the extra time out. So there are patient factors and societal factors. Whether or not the plastic surgeons offered a reconstruction also differed. This crosses unity here, but as you can see, the point is exactly the right direction. We just have smaller numbers, and they were less likely to have reconstruction. So the overall was the disparity. This was my first disparities project. I ended up getting my dream job at Boston Medical Center. My dream job at UMass. Before I tried to get a job at Boston Medical Center, BU. I thought I had a dream job there. I thought that they were going to, I figured out finally where all the minority patients are treated in Boston. And they were supposedly offering me a job. I didn't get the job. They gave it to somebody else at I interviewed in my current office right here. But I got, luckily, a great job in Worcester, the University of Massachusetts, Worcester. Now, the Worcester population it's pretty diverse. It's 69% white and 13% Black, and of these, 21% are Latin, and 8% Asian, other including multiple races and Native American, which is about 0.5%, 10%. A diverse population, but differently than Boston, the University of Massachusetts, that hospital actually treats the diverse populations. There are fewer hospitals in Worcester. There are only two main ones. One's a private one and one's the university hospital, which has several campuses. And so actually at the University of Massachusetts, for the first time, I, as an attending, did Whipples on Black patients and Latin patients and white patients and Asian patients. And it was a very different population. And I started to become increasingly interested in risk stratification, especially for cancer care. So this is a group that we started to put together, UMass Walk for Cancer. We're wearing purple for pancreatic cancer, which is my own passion. My son, who is much larger and more mischievous now. But in any case, my early work was not in disparities at that point per se. It was looking for risk of pancreatic cancer surgery, showing that the risk of pancreatic cancer surgery was going down over time, that the complications were not decreasing. And then we ended up modifying the score because looking at the different hospitals and different surgeons and different patient populations had different risks after surgery. So we started to modify our risk scores, which we created for multiple different surgeries and cancers, to reflect individual variation. So this, while it's not on disparities per se, at least for ethnic disparities, still started to show that different people and different groups of people get different care and have different rates of complication and death. So I'm going to run you through a few different research projects that reflect some of our group's evolution in disparities research, all spearheaded by trainees. So Melissa Murphy, who's now a colorectal surgeon, worked with me, and we determined in SEER, which is a database we've heard a lot about also from Dr. Wingfield, is that Blacks present at equal stages. We think, we naively thought then that the reason why African Americans did worse for pancreatic cancer is because they must present at later stages. Well, actually, looking at the SEER database, we found that wasn't true, but they were less likely to be resected and had lower survival. If they were resected, the survival was equivalent, thus telling us in surgery that actually the receipt of care is a major barrier and a major cause of disparities. Melissa further looked using SEER Medicare, these are the SEER Medicare linked databases, as to why. And we found that Blacks were less likely to have a subspecialty visit. And we heard some of this from Dr. Wingfield's great talk, but less likely to see a surgeon, less likely to see a radiation oncologist, and less likely to see a medical oncologist. After a subspecialty visit with a radiation oncologist, they were equally likely to have radiation as whites. However, we heard from the great talks earlier, there's a nuance to that. Dr. Willis pointed out that Blacks are less likely to complete their care in a timely fashion. They were less likely after medical oncology visit to have chemotherapy, and they were less likely after seeing a surgeon to be resected. But after we adjusted for resection and adjuvant therapy, the survival is equivalent. So despite the disadvantages in the Black population, once they got all elements of care, their survival was equivalent. The next part is rankings versus reality, and this is the beware fake news portion. We looked at the Mass Department of Public Health discharge data from pancreatectomy at that point of time. We looked at outcomes, mortality, complications, length of stay. I looked at all the hospitals, and I knew what the hospitals were in the state. We compared with the rankings, US News and World Report, et cetera. And the reality behind this is that outcomes correlated imperfectly with volume. Right? US News and World Report had the strongest correlation, but it was imperfect with outcomes. Consumer Reports actually had a negative correlation. The better they thought you were, the worse that hospital's outcomes were. So I stressed from that ranking systems are heterogeneous and it's a buyer beware. Next, we looked at regional outcomes for pancreatectomy, and the take home from that is that high volume hospital outcomes are skewed by mix. This is Lindsay Bliss's work and Ted McDade's. We had a hypothesis that regionalization has unequal effects. So even though we found in earlier papers that patients are more likely to be regionalized now, go to high volume centers for pancreatectomy, we thought it might not be fair. So we looked at the Mass Department inpatient discharge database I just described, and we also looked at HCUP data, the nationwide inpatient sample. So looking at this, we are able to see that patients, this is odds of traveling less than 10 miles to a resection hospital. So if you were Black, you are much less likely to travel, right? So patients that travel tended to be white. People that were African American were less likely to travel to a high volume hospital. And patient selection predicts outcomes. Most Massachusetts pancreatic cancer patients traveled more than 10 miles for resection, but people that were more likely to travel were younger, white, male, or residing in high income areas by zip code. Using US data, high volume hospital patients had fewer comorbidities, fewer minorities, and worse insurance. Non-white race, non-private insurance, and comorbidity predicted decreased travel or a lower volume hospital. Hence, the better patients, the patients that are more predisposed to do better, go to high volume hospitals. So a lot of the effect that you read about high volume hospitals, people doing better, everybody should just go to, say, Johns Hopkins to get their pancreatectomy. Part of the reason why those higher volume, largely white hospitals, often that are embedded in urban areas that are not entirely white, they serve patients that don't necessarily come from that urban area. They come from the suburbs. They come from people that have the means to fly or drive, to take time off from work to go to those high volume hospitals. So my take home from that is those populations that could most benefit from any high volume effect are the least likely to benefit from it. Next, we looked at variations in US cancer outcomes. This work was spearheaded by Gulnara Kasimova, who is a categorical resident at Dartmouth and worked with me for 2 years. We hypothesized that regional variation exists along with deviations from practice guidelines. This is the NCDB, so this is all different large data. We analyzed this by geographic regions. We did Kaplan-Meier survival curves and logistic regression. We divided it somewhat arbitrarily into West Coast, West Central, East Central, where you are now, South Atlantic, and East Central regions of the country. And my biggest take home here is that many people in the United States do not receive adequate care. So people that have stage 1 and 2 disease, some of them did not have surgery at all. Some of them, many of them did not receive chemoradiation therapy. So no matter who you are in the United States, if you lump it all together, people are still not getting adequate care for pancreas cancer. And in terms of region, the Northeast tended to have the highest survival by region. Again, is this because they are diagnosed at earlier stages, or is it because there's too many doctors in the Northeast? You can see that this is the line here, which where you can see the Northeast has higher survival. It's actually not because we diagnose patients at earlier stages in one part of the country versus another. It's actually multimodality treatment. It's not the stage at which they're diagnosed. It's not whether they get resected. In fact, they're more likely to be resected in the South Atlantic and East Central regions of the country. They are more likely to get multimodality treatment. So the survival difference is all of us. So it's surgery, radiation oncology, chemotherapy. So finally, in terms of the review, I wanted to talk about how insurance affects outcomes. This is work done by Gillian Smith that was linked SEER to US Census data for survival, and these are median survival. These are percent uninsured. So this is the higher on this axis, the more people are uninsured. And here is median survival. So you can see in the highest uninsured regions have the lowest survival across 10 different solid tumor types, whereas the ones that have the highest insurance, the lowest uninsurance, have the highest survival. And the background, some background for this is, as you know, Massachusetts is a harbinger of many things, some of them good, some of them bad. But Massachusetts was instituted Romney Care before the Affordable Care Act. And so our swing point was here. So it was instituted in this period of time. And as you can see, we were already a pretty highly insured state, but we've actually dropped below 2% in 2020. And so this is a cartoon from a long time ago with Romney and Obama, of course, is kinds of care. And as the Affordable Care Act is under pressure now and under extreme pressure, if the Supreme Court justice is approved, I think there will be an enormous effect on all of our care outcomes. But this is Miriam Eskandar, who is a fellow at the Ohio State University, who was a resident of Beth Israel Deaconess, did this work. She looked at the nationwide inpatient sample, both for Massachusetts and nationwide, and found that with the institution of Romney Care, that there was a distinct difference in the slope of people that were undergoing colectomy emergently as opposed to elective cases. So as you can imagine, a perforated colon cancer operated on emergently has a very different outcome, both from an oncologic and from a performance status point of view and a quality of life point of view for the patient. And after near universal healthcare was established in Massachusetts, the rate of emergent cancer operations decreased significantly. So these are some numbers of the team that did much of the work that you see. So now that we're here in 2020, and now that we are looking, we've heard so eloquently by the previous speakers, heard about the tremendous inequities in cancer care. Where do we go from here? This is my son. This is not an election picture, but I do obviously urge everybody to vote. This is my daughter. Where do we go from here? So I ended up finally in 2017 getting my dream job, a little bit different job description, but it's still my dream job. I ended up at Boston University School of Medicine and Boston Medical Center, both equally important. BU was founded as the New England Female Medical College. It was the first U.S. institution to train women as physicians. In 1864, Rebecca Lee Crumpler, the first Black female physician, was graduated. She actually served at great risk to herself in the post-Civil War Reconstruction era in the South, and then came back to Boston and lived in Beacon Hill, which was then a Black neighborhood, and took care of patients in Boston. I actually just was very pleased. I actually contributed funds, and she and her husband finally now have a gravestone, a marker in Hyde Park to commemorate her and her amazing life. In 1873, it merged with Boston University and became BUSM, and also graduated the first Native American MD in 1890. And Boston City Hospital is also another storied institution. It was founded in 1864. It was the first municipal hospital in the country. So what that means is the other kind of general hospitals were generally founded as charity hospitals. So rich people would give alms to the poor to get them off the street when they're sick, and found the general hospitals as charity hospitals. The rich people were taken care of in the clinics, if they went to clinics, and in their own brownstones by visiting physicians. But Boston City Hospital was founded by the city of Boston because the city of Boston felt it shouldn't be charity, it should be based that healthcare was a right and that the citizens of Boston were entitled to it. So Boston City merged with the Boston University Medical Center Hospital in 1996 to become Boston Medical Center, where I am today. Its stated vision, is to make Boston the healthiest urban population by 2030. So BMC is Boston's hospital. In 2018, the ACO was started, which gives us a broader mandate, so we take care of patients actually from outside of Boston and from all over New England. But as you can see, I'm in the South End right now. This is Boston. This is where our patients come from. Some of the people in the outer suburbs go to the other hospitals in Boston. So this is the Boston race data. Remember what I showed you before for Worcester. So Boston is actually more diverse than Worcester is. 45% of Bostonians identify as non-Latinx white, and 25% identify as Black. Latina identifies as 20, and then Asians are about 10%. So that's the Boston racial data. The people of Boston come here. So we are a $3 billion health system. Its mission is to serve our society's most vulnerable populations in Boston. BMC patients, many are low income, people of color residing in Boston's most working class and poorer neighborhoods. More than 70% of our patients identify as a minority. 50% of our patients have an annual household income below federal poverty line, and more than 30% speak a primary language other than English. As a point of comparison, BIDMC, where I most recently was, and Brigham and Women's Hospital, where my husband works, less than 15% of the patients come from those low-income brackets. So this has been an insane year for everyone, right? It's the worst of times in many, many ways. Not that things are suddenly worse, but maybe our eyes are awakening to things that have existed, problems that have existed in our society. We feel like we're at a watershed or an inflection point, and I think at least we at BMC have made it our goal to actually work toward achieving health equity. Health equity is the absence of avoidable, unfair, or remediable differences in health outcomes among groups of people. So what are those? Economic status, race, language, behavioral health issues as well. So this is the year of COVID. This is the year of some people realizing that Black Lives Matter, and the structural racism and systemic racism that we have as part of the founding of our country. Our COVID response at Boston Medical Center was fueled by our recognition that when we looked at our patients, BMC was 70% COVID at its height. The people that were dying of COVID, the people that had COVID, the people that were predominantly affected by COVID were people of color and people from low-income areas. And it is, two of my residents, Elena Geary and Michael Polson, have published papers recently showing that COVID, it kills minorities, it kills Blacks, it kills Latins, it kills Asians, right? It's an amazing disparity. So our response is really fueled by our desire to take care of basically our patient population. So it magnified our existing disparities, our lens on it. So you can see with COVID, you can see how many people, it does disproportionately in communities of color. There are racial disparities in healthcare outcomes among Boston residents. I'll just focus on oncology, on cancer, but Black residents in Boston are 1.5 times more likely to suffer premature death from cancer. And I will point out to some of the questions in the chat and what Dr. Wingfield was saying too, that the Boston Globe, looking at the National Federal Reserve data, found that the average Black family in Boston has a net worth of $8.00. $8.00. The average white family in Boston has a net worth of $275,000 in Boston. So systemically addressing racial inequity will require actions to address the drivers of health inequity within our hospital and our communities. One thing that this has taught us, is that we can't be smug. Just because we take care of all these patients that are our patients it doesn't mean, it certainly doesn't mean that we don't have structural bias and structural racism and disparities in care in our own institution. So who better to turn that around? Who better than to figure out where we fail and where we fall and make it better? So the context is huge, right? So there's a socioeconomic and cultural context. There's disease burden, which we do know how to, or at least for medical professionals, but there is bias in clinical decision-making. We've shown that people that come in with cancer, with any other kind of pain, sickle cell, if you're Black, you're less likely to get pain medicine for your pain. And people are going to rate your pain as less painful. And then negative patient experiences. If people are treated differently by the staff, by the largely white doctors at our institution and CEOs and administrators, that leads to a very negative patient experience. So these couple slides I don't want to go over them in detail because it's a little bit, but I just wanted to share with you, there's a tremendous amount of work that goes in. You can stand up and say there's disparities and we're going to eradicate them, but you actually have to, so I've learned now in middle management, you actually have to break it down into concrete steps and have groups and make decisions and move forward. Right, so there are multiple facets on which we need to act and are acting and meeting in subgroups and various Zooms to improve health equity. We're from the clinical care, research and clinical trials, teaching and education, and our advocacy piece. So again, a org chart. I'm in this equity oversight group. We have a whole bunch of like the administration and the leaders and chairs participating in all these groups. And there's a charter there. I could share with you 100 PowerPoint slides, but I won't. And on all levels, as a chair surgery, I feel like a middle manager. You feel like there is always some gap between what the actual patient experience is, what the providers experience, and what administration is trying to do to advance health equity. But you need to stay in the game to change the game. So to put it into perspective, this is a shot by one of our MAs, our medical assistants, from the second floor of the Moakley Cancer Building, where we take care of cancer patients, of our doctors, some staff, taking a knee in honor of George Floyd for 8/46, and we're over here on the side here, but it was so on some level we need to address things with passion. We need to address things by demonstrating, and we need to address things systemically. These are some of me beforehand with some of my chair friends, right? So the chairs of ophthalmology, ER, pediatrics, neurology, anesthesia and family medicine. So on some level, you need to decide things in chair groups and at leadership of clinical departments. And on some level, these are my trainees, right? I was taking a picture of them. On some level, we have to address our trainees, our education, like who are we training and how are we helping them have an eye for disparities and be part of the solution. Some of the work takes place in casual settings, right? So this is after the White Coats for Black Lives demonstration. I invited some of the organizers to my house first, and this is the second one. These happen to be women, we want to talk not just about how we are going to demonstrate, but how we can actually change things. This is Sadiqa Kendi, so a little squee there, but she and her husband have moved to town. She's our new chief of pediatric ER. and is part of this health equity initiative. But we have to make structural changes. So in my department, I have just realigned the leadership of the department to appoint Dr. Jason Hall, who is our Chief Colorectal Surgery, as the Associate Chair for Academic Affairs and Faculty Development. So he's going to help me oversee all aspects of the department, from recruitment to retention to development to promotion, to run leadership training and implicit bias training, and to really think about what it means to have an anti-racist department of surgery that takes good care of all cancer patients and patients with other diseases as well. Sabrina Sanchez is his deputy and will assist in this regard. In the Department of Surgery, we have established SOAR to evaluate disparities in cancer care and in surgical treatment of cancer care, to identify best models of complex care for surgically related diseases, and develop cost-effective models for care of population health. We're working with our ACO to embed this sort of system-wide. And we've also established a second equity project in cancer, which is split from a $1 million seed grant from some donors. But we are funding a diverse biobank with clinical data that's phenotyped, that we are providing navigational and social support for at-risk and active cancer patients. I actually even modeled on a BMC catwalk, embarrassingly, on a fashion show to raise money for our patients. But the most important part of that catwalk is not the doctors that are supporting. The most beautiful models in that are the cancer patients, and they'll see those cancer patients walk with the kind of breast cancer that Dr. Willis was describing down those catwalks with their children and their parents, and everything else is really something that will make you believe that we're going in the right place. And finally, the trainees, right? So the trainees are incredibly passionate. They are well-meaning, they're idealistic, they care. We at BMC and you really care very much about training the next generation of doctors, cancer doctors, surgeons, surgical oncologists. They have founded a group called Surgical Equity that advocates at the State House, advocates for our patients. And when I see them, I really do believe that in Boston, at least at Boston Medical Center, we can try to be, a city on a hill, a model for how to do healthcare right, and how to have a constant view of how to make things more equitable. So, I remember that boring org chart where we have, the CEO and chairs and all this kind of stuff. I actually volunteered that we need a trainee at the table, that we need to be able to actually have voices at the table that both speak from the trainee point of view and also who are in touch with some of the issues that actually our patients face. So this is Elena Geary. She's a third-year research resident. She's a PGY5 then, but a third-year research resident with me in our program, who we're very proud of. She actually grew up in West and Southwest Philly as in one of those redlined areas. She to this day supports her mother, pays her mortgage. She's obviously a first in college person, and she is going to be part of this equity advisory group to steer the rest of us, to help steer the rest of us, and be a voice at the table. So thank you very much for your attention, and thank you all so much for organizing this important symposium.
Really outstanding. And now we'll move to the panel discussion part of the program. And so we have 9 questions on queue, but I would like to open the discussion up with a question to kind of tie all of this together. All right, so Dr. Singh, you mentioned that the Patient Protection and Affordable Care Act is potentially under assault based upon a Supreme Court nomination. In the view of the panel, tell me what that means for the care of patients with cancer, and more importantly, our march toward equity in cancer care.
Well, for me, as I mentioned in my presentation, the direct impact would be on screening. Currently, the Affordable Care Act mandates that screening is covered. And when you think about that, you're talking about $100 or so per year for women ages 40 and above, versus as we demonstrated in those slides from the American Cancer Society, you've got 20% of cancer patients who are going to present younger than age 50, where they could eliminate it such that they didn't have to care, they wouldn't have to cover it at all, or they could move back to the age 50, either way, to try to reduce costs to insurance companies. And so this is a big deal for the patients that I see, and I'm sure for the others, particularly when it comes to screening.
Yeah. So in addition to some of the challenges around screening, I think it will also significantly impact prevention strategies. As you may have noticed in my slide when I talked about lung cancer, we're finally starting to get on top of some of the incidents, and a lot of that's related to tobacco cessation programming, which is paid for by Medicaid and other kind of insurance products. What's been striking is, for me, going from Boston, where you saw Dr. Sang talked about the fact that we had Romney Care before Obamacare was there. And I came from a state where we had 4% uninsured rate, to North Carolina, where, as I mentioned, some of the counties that the Cancer Center serves have 20 to 30% uninsured rates. I can tell you that people present with more advanced disease in that state simply because they don't have access. So it's not just about screening, it's about prevention strategies. It's about making sure that when people are diagnosed with cancer, they've had an opportunity to have strategies related to their diabetes and hypertension, because those things, the chronic illnesses, those comorbidities, absolutely impact outcomes. And so if we're not just dealing with health in general and well-being in general, if people do get a cancer diagnosis, independent of screening or not, we cannot treat them oftentimes adequately or efficiently if they have other comorbid conditions that prevent us from giving them the best surgery that they need, or the highest dose chemotherapy, or frankly, from a radiation perspective, obesity significantly impacts our ability to treat patients and treat them well.
Also, cancer is a pre-existing condition, right? So a woman has breast cancer at the age of 31, say my cousin, right? That's a pre-existing condition for her entire life. When she applies for insurance or et cetera, that's a pre-existing condition. It recurs, it's a pre-existing condition.
And also, along those same lines, you're exactly right. Pre-existing conditions, and there's a cap. I remember as a fellow, we would run into situations where a patient may be on their second cancer, and they would hit that cap, regardless of what the insurance company was. There was about a $1.5 million cap, and when you hit it, you were out of luck. No insurance company had to pay a dime. That cap was removed with the Affordable Care Act. So that cap can come back into play, such that a person who, just as Dr. Sang said, may have a cancer at 31 and then may have another cancer in their 50s, and then they hit a cap and there's no more coverage.
Yeah, and that's vitally important now with all of the targeted agents that we have, because they're so costly and expensive. I mean, people can spend up to $40,000 a month just for a medication. But even if it was just about surgery, it's amazing. I mean, I didn't realize how costly healthcare is, and that's part of the challenge. I think we've been a little bit divorced from cost, until my husband got sick, and one hospitalization can cost $250,000. So how do you deal with that if you do reach the caps? That's a great point, Dr. Willis.
Great. So we have questions here from our online participants. And so the first question is from Dr. Grippo, and I believe Dr. Wingfield partially answered this in the chat group. So I'll just read it and see if there's any additional input from our panelists. So the difference in economics between whites and blacks is absolutely striking. Where the lines on the graph averages is this accumulated wealth of funds garnered through employment. The numbers in older individuals is highest, and for whites, this was above $300,000. It would be nice to know how these data were collected, since it seems rather high, unless the variance comes from those who are extremely wealthy being predominantly white, which is likely. If those individuals are removed, let's say those with over $10 million, would the curves remain equally disparate? Though there is no doubt that there would still be some dramatic difference. So Dr. Wingfield, would you like to go over your answer to Dr. Grippo?
Yeah, sure. And thank you, Dr. Grippo, for the question, because it's very dramatic, isn't it? And you're right in the sense that the graph that I showed were averages, and indeed included individuals who were in the top 10% of the wealth bracket. So that's top 10%. That's even lower than, than $10 million, frankly. But there still is a significant gap along the trajectory. So at each age bracket, for each kind of income level, Blacks are doing worse. And, it's really striking when you actually look at it state by state. And I know Dr. Sang talked about what's happening in Boston. We did a similar wealth analysis here in Winston-Salem. And this is not unique to any one place in the country. This is something that, again, really drives home this point of systemic racism. Dr. Willis talked about redlining. That happens in every state and every city. So this is something that has been very strategic in terms of this, this desire to squash the capacity of Blacks to build wealth.
I will say that the Boston Globe data they're medians. So that ends up negating if someone has $100 million, it's a median. So they're not averaging it out. So Bill Gates doesn't average out, et cetera. He's just a high outlier.
Yeah, and so you can look at this data that I presented. It was from the Brookings group. So you can take a look at that.
And likewise, the data that I presented from the 2010 census was a median. So again, that's median home value. And you could see, again, those stark differences. And as home value is the primary source of wealth for most families, you again see that large six-figure difference in the data that I presented as well. So that corresponds exactly with what she reported.
Okay. So we have, they look to be a couple of statements from Dr. Prince, but I will turn these into to questions for the panel. So at UIC, we have an environmental health sciences core center. And one of the foci is understanding racial disparities regarding environmental conditions across neighborhoods that underlie increased disease burden. For example, poor air and water quality and dumping are rampant in Chicago's African-American and Hispanic neighbor communities. And the core actually has detailed measures of this. So what are some of the approaches that the panelists see to addressing these important issues that actually turn us from an issue of biologic differences to issues of structural violence and subsequent incidents, differences in incidents and outcomes from cancer?
I think from my perspective, really the thing that I can speak more towards, which is a little different from your question, actually has to do with food deserts, for example. So that has a tremendous impact upon health. When you look at these areas, I will say, for example, during my time at Temple, this was not very long ago, and they just had their first grocery store within that entire area. So they were more than, if you lived there, the nearest grocery store was more than 5 miles away. So they would have to go to corner stores, canned foods, high sodium. That was their diet. So they opened up their first grocery store literally right on Temple University's campus, but that was the only opportunity for those people in that neighborhood to access food. So that almost speaks in line with the slide that I showed in the UK, showing neonatal mortality mirroring coronary artery disease. So these issues that you have that are structural, whether it's lack of grocery stores, lack of safe spaces, high incidences of violence, as you have in Chicago, Philadelphia has come right up behind you over the past year or so as the number 2. These are huge issues that impact stress, trauma, and over the long run, particularly when it comes to diet and the like, can have an impact on cancer.
Okay. So I have a question from the audience for Mrs. Rogers. Mrs. Rogers, what's the difference that you've seen over the last 25 years in terms of researcher interaction and other conversations?
I would like to think that things have improved over the last 25 years, but the more I speak with people, the more I'm out in the community, things have actually gotten worse. You would think that within 25 years, treatment options that are available for people would improve. I just spoke with a woman last month who has had an issue for 2 years and was not able to get any type of treatment. So she finally went in and just found out she has stage 4 breast cancer. She said she was uninsured, trying to get in to see a doctor. Everyone kept putting her off, and she just gave up on it. And you would think that in this day and age, something like that would not be happening. I've also, the other thing I can speak about is we like to think that we could talk with each other now, but think about someone going in to see a doctor and they present to the doctor the issues they've had, and the doctor basically is blowing people off.
Okay. The next question from the audience. Let's see, disparities is a known issue, particularly in the treatment of cancer. However, what is being done to actually include uninsured or underinsured women from any ethnic background to be included more than those who are insured? So I think this question gets to Dr. Winkfield's statement about what equity actually looks like, because some groups actually need more care than other groups. So can the panel address national issues to manage cancer, particularly breast cancer in under and uninsured populations?
So the challenge with the way that our healthcare system is structured in the United States, at least from an insurance perspective, is that it's run on a state-by-state basis. And that does make it a challenge. As I noted, most states in the United States have accepted Medicaid expansion. North Carolina has not. And so that does mean that there are fewer people who are eligible for insurance. But there are really directed programs. So for instance, there's the BSEP program, which is for breast cancer and cervical cancer, where women who are uninsured or underinsured can get screening through that program. And if they have a positive diagnosis, can then get access to Medicaid. But there's an awareness issue, right? So how many people who are in the underserved category know about these types of programs? And this is where kind of making sure that we are talking about these programs is really vital. Some states, like Virginia, actually has a similar program for colorectal cancer, which, as you know, really impacts African Americans, particularly young African Americans, and that's been highlighted with the recent death of Chad Boswick. So it's really important, again, to start thinking about how can we improve screening strategies. But again, it does not negate the importance of prevention and just access to healthcare in general, and that's a much harder ask.
Great, great. Anyone else from the panel who want to approach that? Okay, so here's a question from Dr. Watson, our Associate Director for Community Outreach and Engagement. Thank you for pointing out that trials that inform the United States Preventive Services Task Force guidelines often were not reflective of populations that carry a disproportionate burden. How can we promote more diversity in the trials that inform USPSTF guidelines on how we can also ensure more diversity of the type of researchers that sit on the USPSTF?
Great question. I think a couple of things to take into account. While systematic reviews are an excellent way of reviewing, I think that this is a particularly good example of the bias that can occur. So what this came from was they did a systematic review, which means that they were reviewing prior studies. So you have an inherent bias from the fact that you are reviewing studies that were produced, meaning that you're not looking at an entire population, you're just looking at the population served by those who published the studies. And in this case, many of the studies were Norway, Sweden, only a smaller proportion actually were from the United States of America. And as we talked about, Dr. Wingfield talked about in clinical trials, when you have 3% African American, that's not reflective of the population of the US. So I think that if we're going to make, or whether we're making policy decisions or saying things that could impact policy decisions, we have to make a conscious effort to represent the United States represent the people who are going to be impacted by those decisions. And that is both the selection of the population that's studied, as well as, and that's an important point, selecting those who are on the panel making the decisions.
Great.
So Dr. Stewart, I just want to comment that this is one of the important reasons why we have got to get involved in the legislative landscape. It's really important for people to know that they have a voice. And I bring up the example, when I was in Massachusetts, we did not have oral parity laws on the books. And if people don't know what oral parity is, there is a little bit of a loophole in the legislation around insurance, that there were some insurance providers that would say, if you are not getting chemotherapy by IV, that there was a higher copay. And so you can imagine what that meant for women who may have a breast cancer diagnosis and needed to take a pill, tamoxifen, which is a systemic therapy that is known, data shows, improves overall survival, that those women who are taking that medicine, either the insurance could say, we're not going to cover it, or we are actually going to require a higher copay. Oral parity laws now exist on the books in over 41 states. There are still a few who don't have it, mine included, but what that has done tremendously is actually improved equity and the ability for patients across a broad spectrum to have access to medicines. I can tell you, when I was in Boston, we literally marched on the Hill. Like, you have to use your voice. And we got together our Black sororities and fraternities and had them get on the Hill with us. And we kind of really, it has to be a ground effort. And what's important to really think about is, how can we empower our patients' families, caregivers, communities, providers, to actually get engaged in the legislative process, because we can make a difference with our voice.
Great, great.
Dr. Wingfield and I met at ASCO in the Disparities Committee, even though we had been at the same institution for some overlapping periods of time. And I will say that both ASCO and PanCAN, Pancreatic Cancer Action Network, and probably some other organizations I've been with too, have done a lot on teaching you how to advocate. And so I think patients can be a very strong advocate, but who actually has the time and energy to advocate are generally the populations that are not disparities against, right? Or minoritized populations, et cetera. So it's a catch-22, and how we can contribute to get our patients to actually have a voice and feel like they have a voice. I have like thousands of postcards actually to write to North Carolina actually, but how we can actually encourage people that they have a voice, they have a vote, if they're a constituent, their congressperson is going to listen to them, and whether it's at the state level or at the national level, empowering these people to use their voice.
So 2 points around that, and I learned this lesson around advocacy very early. So a lot of times advocacy is related to survivorship, right? And so if we think about the advocacy activities around breast cancer, that is so much more significant than were the advocacy efforts around lung cancer. And so 15 years ago, there was such a disparity in survival that you actually had women and men who had survived breast cancer that were willing to march the Hill, meet with their legislators, and advocate for policies that were favorable toward their conditions. And I think that we are continuing to see that carry out. Kind of the second part to that is that there are many organizations, including the American College of Surgeons, that have set up links that are very easy for you to access your congressperson. So for instance, and Jennifer, I think we have talked about this, is the fact that they are looking at changing reimbursement for surgeons across the board. And so all you have to do is go on the ACS website, type sign in, and they automatically have your congressperson figured out. And you just hit a button that says send letter. And that goes to the congressperson. And I will tell you that without fail, as Dr. Singh mentioned, they will answer you because you are a constituent, and they rely on your vote to keep their jobs. Okay. See, we have another question here. Is there any way we can receive cancer screening before 50 years of age? Some hospitals and doctors are suggesting 50 years old for mammogram, unless you have a family history of breast cancer. I think Dr. Willis?
So exactly, that's the real impact of the U.S. PTF, the U.S. Preventive Services Task Force. That's where the impact comes. The Affordable Care Act is mandated that you can receive annual mammograms from age 40 and above, but you are then told by your primary care doctors who accept that, often not having read the fine print, which I went into in that discussion, that they actually said that that the benefit does occur sometime between 40 and 49. So this is what I'm worried about, is you have the gatekeepers may tell patients to not receive screening that's already covered. So you can receive by law screening mammograms age 40 annually every year from 40 on up.
And it's important to know that you do not need your primary care provider to get that screening done.
Precisely.
And so go around them if they're preventing you, and then find another doctor. It is okay. If your doctor's not listening to you, you find somebody else. Please.
That is, I agree 100%. Go around them and find somebody else.
Okay, we have another question here. So what steps have the panelists taken on their end to connect with people such as Mrs. Rogers to basic scientists at their institutions? Basic scientists will be the ones asking the questions to address biologic disparities.
I think that's the point of our biobank as well, just to some extent, is to have a diverse biobank and oversight that has community members. BU, before I got here, our BMC before I got here, got in trouble because they were talking about creating a biobank without having, they didn't have enough community representation at the table. This is decades back, but when Congressman Moakley was still alive. So they are very careful now to have oversight of their boards, on their IRB, on everything to, that the specimens, as such as they are, while they'll be phenotyped, are absolutely, we all know the story of Henrietta Lacks, right? That are absolutely used in an ethical fashion according to the wishes of the donors, as it were. And then also, I saw that Ms. Rogers asked a question about, are you getting people on your, how are you getting advocates, patient advocates connected in your leadership? I think our equity board is filled with people from the community, and it was actually hard on some levels to get people, because a lot of the people that want to do good and approach to try to be on the board are not people that live in Dorchester. And so we actually had to go out and approach. There's actually a preacher who used to be a famous TV anchor here. She's on our board. It's really a lot of fun to actually open the door a little wider and find people of the community that comes to Boston Medical Center to serve on all the various boards and leadership capacities. But you are doing, if you're talking about minorities, you are doing a minority tax, because these people are incredibly busy. Everybody's asking them, especially now since George Floyd, everybody's asking them to contribute 4 times as much as everybody else and still live with the burden of being a minority in Boston, right? So it's hard. You invite people in, you have to be conscious of their time and how much you're asking them to do.
So Ms. Rogers, one of the things that I did in my role in North Carolina was actually to develop a community advisory board. And it was made up of diverse populations. What people don't realize is North Carolina has the largest American Indian population east of the Mississippi, but yet our institution really hadn't been doing anything. Our cancer center hadn't been doing anything to focus on the issues related to disparities in the American Indian population. Similarly, I think African Americans were sitting right there in Winston-Salem and nobody had really addressed them. And so I took it upon myself to say, what is it that my office can do to really help augment the work of the Cancer Center? And so we really started having town halls and getting involved in really doing community assessments to understand some of the needs. But we really felt, like you said, it's important to have the community voice. Now the challenge is with the basic science, because like you said, when you went in to review those grants and all of a sudden you're sitting here like, whoa. So one of the things that we developed in our office is an Advocate for Research in Medicine program, which is a training program that teaches lay individuals about research, the different phases of research and scientific research, and also some of the concepts in basic science. Now, our goal is not to make everyone themselves scientists, but for them to have a broad enough context so that when they are sitting in front of somebody, because what we do then is we pair our patient advocates with the researchers, right? But the researchers have to have a general context. And so we've really created that training program to help provide individuals from diverse backgrounds
with the information they need so that they can sit on these boards, so that they can sit and have conversations with scientists and ask the questions that are needed. And similarly, we are doing education with the basic scientists so that they can learn how to speak to lay individuals, right? Because it goes both ways. It's called bi-directional communication for a reason, but sometimes the scientists can be so high up here that they don't necessarily know how to break things down. So we actually have a training program, if you will, for our researchers there as well. Thank you for the question.
And you know what, that is the ideal, because I remember I knew nothing. And over these 25 years, I have learned so much. And I take the knowledge that I have out into the community, and there may be one person, the light bulb goes off and they want to get involved. And that's what it's about. I mean, if we don't do it that way, there will always be a disparity. And everyone has to step outside their box. I appreciate what all of you are doing right now, because it wasn't that way when I had cancer. As I said, I had to fight to get a female radiologist. There just weren't any around at that time. And it meant so much to me to just see a woman, not a Black woman, but a woman. And still now, 20-something years later, it's hard to find that. So thank you.
Great. So I would like to open the mic to Dr. Kitietsky. He has a question for the group.
Thanks. Can you hear me?
Yes.
Okay, yeah. So thank you. Yeah, my question was around the reaching out to legislators and advocating on behalf of biomedical research. You know, we all here at this group are aware of the power of reaching out to our legislators. But I've worked with the advocacy group Research America, and they found that the average citizen has very little knowledge about the biomedical research enterprise, and that gap needs to be closed if we're going to seriously advocate at the legislative levels. You know, there's a feeling that if it's only biomedical researchers and cancer specialists and pop health specialists that are fighting for legislative action, it doesn't really reflect advocacy across the country. So Research America has tried to develop methodologies to help citizens in your neighborhoods understand the impact of research and jobs that come from the NIH and from the hospital systems and how that impacts your neighborhoods. I wonder whether any of the panelists had thoughts around reaching out more broadly to folks in your community to advocate at the legislative level.
Well, thank you for the question. I think a lot of us on the panel do. I actually work very closely with the American Cancer Societies, their Cancer Action Network, so ACS CAN. They do a lot of work around trying to do education with lay individuals. But to your point, I think we need to do a better job at educating people about the importance. And I do think COVID actually is going to help with that, believe it or not. There are some good things that happened from COVID, including us being able to see each other's faces on this Zoom call. We're hearing more and more about research related to the development of this virus or related to their therapeutics related to COVID. And so lay people are hearing it on their televisions now in a very different way than they did about probably any other disease. So this is an opportune time for us to really start to think about, are there ways that we can do broader work? I mean, certainly the Advocates in Research Medicine program that I spoke about, it's a smaller cohort, but now again, because of COVID, everything's virtual. So is there a way to make some of those educational things that we've developed in-house, perhaps for each of our groups, more broadly available to, individuals at large?
So Dr. Wingfield, I'd like to thank you for mentioning ACS CAN. The University of Illinois Cancer Center has been a very strong, has had a very strong presence in CAN. And in fact, we help lead the drive in the state of Illinois for patients on Medicaid to be involved in early phase clinical trials. Let's see, we have a question from Dr. John Nittis. I would like to come back to the question that was raised about meta-analyses. Since the studies in the literature are so lacking in comprehensive coverage, how are we going to be able to generate actionable data quickly? think Dr. Willis, that was with respect to your discussions around screening, around the way that screening paradigms were created.
Right. Well, one source, and that's why we looked at the NCDB, which comes from the American College of Surgeons. It really covers about 75% of patients, and you can get larger numbers through sources such as the NCDB. The study that you saw looking at registries, those are also very helpful. And particularly for the study that we published, coming out of a place such as Temple, that's where much like BU, they're taking care of a vulnerable population. So those of us here in the United States, those of us who are taking care of diverse populations, it's important for us to do that research. It's important for us to publish. So that when I talk about research, educating, acting, and leading, I think it's incumbent upon us. Just as you have at UIC, you have a very diverse population. So it's incumbent upon us to try to carve out that time and report on the patients that we're taking care of so that our patients are appreciated as being important, and they're out there in the literature, and then the focus turns to those patients. It's incumbent upon us to do that.
Okay, I have a question from Sarah Rittner from the audience. Currently, there are significant discussions regarding federal funding not allowing research or activities based on equity or diversity and inclusion to continue. How are we as professionals responding to these concerns? So so I will start that discussion. So I think that there are a number of issues at play. So I think first this issue around research activities related to equity and diversity actually stems from a recent dictum from the White House that they actually wanted to stop diversity and inclusion training because they thought that it was quote unquote un-American. I think that has subsequently filtered down. I think that the events that will take place in about 3 weeks will help us begin to address some of those issues and make some of those issues go away. I think, again, this gets back to a point that I think each of our panelists have made, is that it is important for us to become, or to continue to be involved in the political process so that issues such as these stay at the forefront and making sure that we can address them in a timely and effective manner. Any thoughts from the panelists regarding that issue?
Agreed. It's a political issue.
Yeah, I was going to say, I always have something to say, Dr. Stewart.
Yes, and I love it.
For those of us, there are so many of us who've been doing this work for decades. And trust me, it will continue. you find a workaround. And even in terms of education, even in terms of educating people about the importance of understanding how racial justice matters and why it matters and how we can actually teach people how to think about their own implicit biases, there will always be workarounds for that. For those of us who have been beaten this ground for a long time, we won't stop.
Yeah, just if they fire all of us, what's going to, or defund all of us? They don't have the energy. They're just trying to use this to scare people. You have to, find good trouble and speak the truth.
Great. Let's see, another question. We have a question here from Mrs. Rogers again. Mrs. Rogers, would you like to ask your question for the panelist?
Well, yeah, in this day and age of COVID, and I actually got invited to sit on the COVID task force at the University of Illinois, but research has become politicized. And I hear the question all the time from people about why should we participate in the clinical trial for COVID, because it's not going to benefit us. Or I have a mother, a brother, sister who went to the hospital and they weren't accepted into the hospital. And the first thing they say is, because I'm Black. I can't dispute what they say to me because I wasn't with them when they went in, but trying to change that mindset that when someone of color goes to the hospital, they talk about not being accepted into the hospital, having to go back home. What do you do in a case like that? Because it is a big issue with minorities, not participating in the clinical trials. I've talked with people about taking a vaccination. I know very few people who right now will go ahead and participate in that clinical trial for vaccinations.
So I can speak from my experience, and I think I have 2 data points to kind of guide the conversation. So the first data point is around medical mistrust in the African-American community. That is real. Okay, that is real. Yeah, I moderated a session for the Congressional Black Caucus about 3 weeks ago around that, and that is a real phenomenon. And so the way that I think that we begin to understand this was taught to me when I was a junior in medical school, and we were doing a student-run clinic in Southeast DC, and a woman came up to me and she said, everybody's got this auntie, right? And she said, listen, why don't you come see us when you don't need something, okay? And so we have to get into the communities, expend the sweat equity, and really build the trust. And I am proud that UI has continued to do that, but I think that as a profession, we need to do more of it. The second thing is, the second data point is that that medical mistrust has only been amplified in the current political situation, okay, specifically around COVID testing. So I'm part of this group, it's called the social media ecosystem, and there are a lot of people in that group, and these are fairly well-informed people who were really outraged at the fact that the presidents of Dillard University and Xavier University, 2 HBCUs in New Orleans, wrote a letter encouraging people, particularly their students in the community of New Orleans, to be involved in the COVID trial. And so there was all of this backlash. And so I called a lawyer friend of mine who really piped up against the vaccine. And I said, hey, listen, help me understand this because I'm not really understanding it. And she said, many people think that this is Trump's vaccine. And if it works out, then he's going to get reelected, which I still can't put those pieces together. But there's still some of that going on in the community. And again, we have to have active community involved education to build trust, help people understand the process, but also build a community to benchtop model in which most of our research is really framed in a question from the community that is important to the community that will ultimately impact the health of the community.
Right. And so Ms. Rogers, your question is so very timely because one of the challenges is we're getting left behind, Blacks are getting left behind in all research, right? And in terms of advancement. So we've got to figure out how to address this. But I tell you, that's one of the reasons why I've left certain institutions, because they were not willing to put in the time and effort to build the engaged strategy. How do we work well with communities? You can't just pop in and out of communities, particularly communities of color, just do your research. You have to be there. You have to be present. You have to be supportive. And as Dr. Stewart said, you have to kind of meet people where they are. Find out what's important to them. What are the issues that are important to them? And if you do that, and you do that longitudinally, then when things like this come up, when we start talking about COVID, and we really do need for Blacks to participate, when we start having those conversations, it's easier. So one of the things that I'm very proud of is I'm getting ready to take on a role at Meharry. And James Hildreth, who's the president there, as you may know, is an amazing HIV researcher and has been all over kind of talking about the importance of vaccine development and talking about the importance of getting communities of color involved in the whole COVID process. But you know what? He can speak to that because Meharry is there for the Black community in Nashville, right? And so having trusted voices, and this is why the NIH and the NCI has to do their work. When they are supporting comprehensive cancer centers, they've got to start holding people accountable. If you're in Boston and you don't have more than 5% Blacks walking through your doors, that's a problem. That's a problem. So stop funding the institutions that are there where that's the case. So we have a lot of work to do. Again, there's some advocacy work that needs to be done around this, but I think the biggest piece is for centers, for institutions, for practices, even individual practices, to really start to engage the community, to be there for the community, and to support them for everything, every part of health and well-being. And remember, health is not just the absence of disease, it's really about thinking about well-being. And when you do that, you build trust in communities. It doesn't happen overnight, though. It does take time.
That is an issue. And unfortunately, with so many people being out of work now, so many people just being able to feed their families, unless there's a health care issue right at that moment, they're not thinking about their health. They're just trying to live every day.
So to that point, one of the things that my team did around this COVID epidemic is we actually did a food drive. We actually fed people and handed out masks, right? Like, you know, let's meet people where they are. They're hungry, feed them, you know? And so your point is so valuable.
Thank you.
All righty, do we have other questions? Okay. So Dr. Kodietsky, do you have closing remarks?
Well, my closing remarks are to once again thank our four speakers. You did a fabulous job of bringing up some hugely important issues, and your voices were loud and clear. We at UI Cancer Center are really, really eager to act upon what we learned from you. And I hope to be following up with several of you to have discussions because I've learned so much myself. But beyond that, I really want to pass the torch to John, to Dr. Stewart, to close out the session. And thank you all for participating. We really appreciate it.
So there's a saying is that, you know, if you can't lean on your friends, you can't lean on anybody. And so I have leaned on three of my very, very good friends and also to really help us understand where we are in terms of defining the unequal burden of cancer care in America. Dr. Winkler did a great job of setting the table. Dr. Willis went through and helped us understand the disparities in breast care in the United States and really helped us understand the social political implications of these disparities and also helped us understand the policies, even from the last century, that impacts the healthcare of women today. And Dr. Singh did an amazing job of giving us a view of healthcare disparities from Boston and understanding how Boston Medical Center, which is the city hospital in Boston, has approached equity both at the administrative level, but also at the grassroots level. This has been very informative, and I think more importantly, it has allowed us at UI Health to appreciate what is going on around the country in health equity. So again, I would like to thank all of our panelists for doing an outstanding job. And Mrs. Rogers, I'd also like to thank you for serving as our community advocate and all of the work that you have done for cancer care over the past 25 years. And we look forward to our continued interactions with you and your colleagues. So with that, I would like to thank everyone for attending and everyone for being engaged and asking amazing questions that have sparked really, really good discussions around the effort. Have a great day. And again, I appreciate your attendance. Bye-bye.
Bye.
Thank you so much.
Thank you.
Bye.